In the name of Allah, the most beneficent, the most merciful. Ladies and gentlemen, on behalf of Chairperson, Department of Ophthalmology and Principal, College of Ophthalmology, Light Vision Sciences, Professor Mohammad Moin, I welcome all of you here on this very important Retinoblastoma Symposium of today. Thank you so much all for joining us today and taking time for this very important event. For the formal beginning of our today's event, I would like to invite on stage Dr. Shajaur Rahman, Postgraduate Resident I Unit 3, for a station of Holy Verses. Dr. Shajaur.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Jazakallah. Ladies and gentlemen, as we all know, Mayo Hospital Lahore is the oldest and the biggest teaching hospital in Pakistan. Established in 1871, it began with the working of three departments, majorly general medicine, general surgery, and eye and ENT. The Department of Ophthalmology has been working since the inception of Mayo Hospital, and it started working with even much fervor in late 1960s when it separated from ENT. Since then, Department of Ophthalmology at Mayo Hospital Lahore is a citadel of ocular oncology, and this program was spearheaded mainly by Professor Munirul Haq Sahab. From 1976 to 1992, he was the main driving force behind leading ocular oncology. His series of orbital lesions consists of about 1700 plus cases, which also includes pediatric malignancies, including retinoblastoma. Upon his retirement, his work was taken up by his very prolific protege, Professor Dr. Asad Aslam Khan, whose orbital lesions series consists of about 2600 plus cases spanning over a year of 27 years. Out of these cases, 35% are afflictions of pediatric population. 65% of these are neoplasias, and out of these neoplasias, 70% are malignancies. Overall, out of these 2600 plus cases, 20.98% to be exact, and approximately 21% are retinoblastomas. So, ladies and gentlemen, it's very easy to discern what sort of a disease burden retinoblastoma poses for us. Ladies and gentlemen, it is after his retirement, the program was taken up by Professor Dr. Zahid Kamal Siddiqui, and lately we have been much honored and we are blessed that this has been taken up by our newly appointed chairperson, Professor Dr. Mohammad Moin. Ladies and gentlemen, it's on the shoulders of these giants that we stand today and look beyond the horizons to deliver the highest level of healthcare and service delivery to these poor patients. Ladies and gentlemen, for the formal proceedings of today's ceremony, I would like to invite on stage our chairperson, Principal, College of Ophthalmology and Light Vision Sciences, Professor Dr. Mohammad Moin.
Assalamu alaikum, everyone. It's indeed a pleasure to see all of you here. I think the idea was floated by Dr. Shabana, and she's worked very hard to come up with this thing, and we've been in consultation. The main idea was to sort of bring about a forum on which we can discuss certain things of retinoblastoma. So the idea was to bring up साउंड गूंज रही है तो क्या चक्कर है तुम्हारा? चेक नहीं कर सके कब तक? अब क्या हो रहा है? नहीं, आवाज गूंज रही है, ये ज्यादा चल रही है। तो मैं सिस्टम भी नया ला के दिया, फिर भी उधर के उधर ही है। नहीं चले, the idea was to get a group of people to, so we've got people from Shaukat Khanam, we've got people from Children Hospital. Thank you very much everyone for coming. So we'll just, I'm going to just go through a brief introduction on retinoblastoma, and as we go through, we'll probably have more participation at that time, and just come up with the how we're going to move forward. My aim or idea was to, at the end of the session, have some sort of consensus of what we are doing and how we can work together to improve the care of retinoblastoma for the patients. And we all have our PG trainees here as well, who will be sort of can refresh their knowledge on retinoblastoma. ये आगे करने के लिए कहाँ से जाना? चलें. So retinoblastoma, I think, is a malignant neoplasm of the cells. It's mostly originates from the cones, and it's most common primary ocular malignancy in children, as we know. It's present in about 1 in 17,000 live births, and is no sexual predilection, and most common in India and Africa. And the highest rate was found in India. And bilateral disease is found in 1/3 of the patients. So the mean age, for the family history, the mean age of diagnosis is 4 months. With bilateral disease, it's 12 months, and its unilateral disease comes at a later age of about 2 years. So mutation, I'm going to basically discuss on mutations on genetic or hereditary disease. Mutation is on RB1 gene, which is a misnomer tumor suppressor gene. The location is on 13q14. Kunderson's two-hit theory, both genes must be mutated, therefore it is a recessive trait, but although both genes need to be mutated in pedigree, the tumor appears to be predominant because that somatic mutation happens in 90% of the people. So although the heritable is on one location, but the other gene is mutated in that period, so it sort of follows a dominant pattern. The term heredity means having an inherit stated and is described in patient or a family with a germline mutation, which is passed to from the previous generation. A new sporadic RB1 can happen, which is referred to as heritable. A unilateral affected child who has one parent who's known to have RB1 mutation is both clearly heritable and hereditary, but obviously not bilateral. So inheritance is 95% sporadic. If bilateral, 98% is germline mutation, and overall disease penetrance is 95%. However, there are mutations which result in lower penetration. So this is a complex diagram of how the genetic of the inheritance pattern is shown in these. The historic overview of the RB gene in 1960, the deletion of the small arm 13q14 was discovered. The genetic mapping improved in the 1970s, and it was localized to for more advanced tumor and treating the other eye with radiation. However, he wanted to save his own son. The first trial of intracarotid chemotherapy was done by Algernon Rees and Robert Elston in New York. This failed, and so experimented with external beam radiotherapy for the first time. This saved eye and vision. His vision improved was saved to counting finger in the right eye, and in the left eye is 20/40. So this is how the radiotherapy was improved, or in that external beam radiotherapy the treatment was improved in his case. But the story did not stop here. Zimmerman's son Larry worked as a banker in Manhattan, and after genetic testing for RB gene, decided with his family and to have a child. Perry was born. She was developed bilateral retinoblastoma at 7 weeks, which was treated with laser therapy by David Abramson. So these are all big names in ophthalmology in the United States. For their second child, they underwent pre-implantation diagnostic genetic diagnosis and had a safe child. Perry, unfortunately, later on developed pinealoblastoma, but Professor Zimmerman knew that as his own son working in the lab identified remnants of photoreceptors in the pineal glands. Professor Zimmerman proposed the name trilateral disease. Perry underwent intracranial intrathecal chemotherapy for the first time to
treat the
treat the
pinealoblastoma,
pinealoblastoma,
and
and
she
she
survived
survived
the
the
trilateral
trilateral
disease.
disease.
She
She
also
also
later
later
developed
developed
osteosarcoma, but still
still
survived
survived
that
that
treatment.
treatment.
So
So
this
this
is
is
how
how
it
it
was
was
involved
evolved
in a
in a
family
family
in the
in the
Zimmermans
Zimmermans
in the
in the
1960s and
1960s and
70s.
70s.
The
The
presenting
presenting
complaint
complaint
for
for
this
this
disease,
disease,
as
as
we
we
all
all
know,
know,
most
most
common
common
is
is
leukocoria.
leukocoria.
It can
Can
be
be
among
among
children less
children
than
less than
5 years,
5
or it
years,
can be children
or
more
more
than
than
5 years.
5 years.
If there's
If there's
less
less
than
than
5 years,
5 years,
in
in
both of
both of
them,
them,
leukocoria remains
leukocoria
the
remains
mainstay of the diagnosis. Other thing which can happen is they can have esotropia, exotropia presenting as strabismus, ocular inflammation, retinal detachment, proptosis, cataract, glaucoma, tearing, anisocoria, floaters, pain. So there are different modalities with which it can present. The differential diagnoses include, as we know, congenital cataract, persistent hyperplastic vitreous, uveitis, Coats disease, retinal dysplasia. So those are the important things. Then we come on to the classification, which will be discussed in detail. Reese Elfwood started off the classification in 1964, which was pediatric salvage following external beam radiation, which was the modality of treatment in 1990s. No prediction was on survival on this Reese-Elford classification. In 1989, chemotherapy was introduced, and after a series of classification, the international classification of retinoblastoma was introduced. Slide 18, Vyom. Ideal classification of retinoblastoma include two components. One is grouping and one is staging. So you can see in the grouping, you have a clinical system of prognosticating organ salvage, while the staging system of prognosticating survival. So there one is organ salvage and the other is so the classification which we'll go through, you'll see a lot of cases, international classification. आगे चलते हैं। ये मेरे पास है। मैं आगे चल रहा हूँ। So this is
Classification, you will see the natural history of the tumor is you have intraretinal tumor, angiogenesis with feeder artery and drainage vein, loss of cellular adhesion and begin to send into the vitreous, invasion of the choroid and of the nerves of the brain, continuous growth can happen, but it happens in only 5% of the cases.
Our main aim is to save life, and the second aim is to save the eye, and the third is to save the sight. The multidisciplinary approach includes physicians, oncologists, ophthalmologists, and geneticists is the mainstay of our management. And the treatment modalities which will be discussed include photocoagulation, thermotherapy, cryotherapy, brachytherapy, external beam, systemic chemotherapy, subtenon chemotherapy, intravitreal chemotherapy, and enucleation. And the take-home message is retinoblastoma is the most common intraocular tumor of childhood. Management requires a multidisciplinary approach. Germline mutations require very close follow-up for the recurrence of the tumor and development of secondary primary tumors. If most solid tumors of childhood are indeed correctly attributed to mutations in germline or somatic cells, then childhood cancer cannot be prevented. The main effort against childhood cancer must be that of early diagnosis and treatment. So the main reason we are here
is to diagnose the
diagnose the
disease
disease
early
early
and
and
treat the
treat the
disease
disease
early.
early.
Sorry,
Sorry,
लाइट
line
ऊपर नीचे
ऊपर नीचे
चली गई
चली
है,
गई है,
but
but
I
I
thought
thought
टाइम पे
time पे
चलते
चलते
जाए
जाए
तो
तो
this is
this is
pretty
pretty
simple, तो
simple, तो
उसमें
उसमें
कोई
कोई
ऐसी
ऐसी
चीज
चीज
थी
थी
नहीं.
नहीं.
ठीक है,
ठीक है?
चलो. Thank you
Thank you
very
very
much.
much.
So
So
we'll
we'll
go
go
on.
on.
We'll
We'll
have a
have a
panel
panel
discussion
discussion
जिसमें
जिसमें
यही
यही
points
points
discussion के
discussion
लिए
के लिए
we'll
we'll
come up
come
with
up
them
with
as we
as we
go.
go.
Thank you.
Thank you.
Ladies and gentlemen, the Department of Pediatric Ophthalmology and Retinoblastoma team in particular, they are catering to approximately 30 plus new retinoblastoma cases every year, which means that there are previous retinoblastoma cases that are being followed up as well as the siblings of heritable retinoblastomas. So the total number of patients that are being catered at one time rises to a very staggering high number. This has all been possible because of very studious and diligent efforts of Pediatric Ophthalmology Assistant Professor Dr. Shibana Chaudhary, whose efficacious resource mobilization, intra-departmental as well as inter-hospital liaison is exemplary. Ladies and gentlemen, none of this we would have been able to achieve if we were working alone. All of this is possible because under the roof of Mayo Hospital Lahore, we also have dedicated departments of pediatric oncology and Department of Radiology. Life around home is of the essence in delivering the best quality care to all the patients, as well as we are actively managing and maintaining relationships with the hospitals in Lahore, like Lahore General Hospital, Pakistan Society of Pediatric Oncology, and Children Hospital, who always help us out in delivering the best possible treatment options to all the patients. Ladies and gentlemen, for presenting the data from pediatric ophthalmology team about the retinoblastoma cases and the way that is adopted once a patient comes to the corridors of Mayo Hospital Lahore, I invite on stage Dr. Aisha Azam, fellow pediatric ophthalmology.
Bismillahirrahmanirrahim. I'm Dr. Aisha Azam. Now I'm going, and I'm the fellow of pediatric ophthalmology in Mayo Hospital Lahore in I Unit 3. Today I will present the retinoblastoma protocols that are followed in our department along with the audit report of the last 6 years from 2017 to 2023. First slide, please. Next.
तो आगे पीछे करने वाला देते हैं।
Slide number. Whenever a family of a child with a retinoblastoma comes to us in OPD, we take the detailed history, do the visual assessment, do slit line examination for anterior segment, and in anterior segment, we specially look for AC cells and NPIs, and do the fundoscopy, and if not possible, then we go for the B scan. We send the patient for the B scan in OPD, and if there is a suspicion of retinoblastoma on B scan, then we do the counseling of the parent for further management and the investigation needed. We admit the patient in our ward, do the basic lab investigation, do blood grouping, send the patient for MRI, brain, orbit, PNS with contrast, and we prepare the patient for examination under anesthesia in our OT list in operation theater. We also refer the patient to pediatric oncology department to Dr. Asim for systemic evaluation and for further plan for chemotherapy. Now I will present the 5-year outcome summary or 5-year audit. The total number of patients that presented to us in the OPD department were 194 and 10 patients left against the medical advice straight away from the OPD and 16 patients expired during the treatment. Now, this graph shows the laterality of the disease that shows the unilateral and bilateral cases from the year 2017 to 2023. In this slide, you can see the total number of patients in blue bar and the unilateral cases in red bar. Out of total number of patients, 90 patients were unilateral and only 10 patients were bilateral. Now this graph shows the disease extent that the patient, that is the patient with the intraocular, orbital or with the CNS involvement. Out of 194 patients, only 89% had intraocular disease, 9% had orbital and only 0.1015% had CNS involvement. Now this graph shows the surgery during the last 6 years. And you can see the maximum number of surgeries in 2018 and there was a decline in 2019 and 20 due to COVID and again there is a rise after that. This graph shows the number of patients received the adjuvant focal therapy, 9 patients received the subtenon chemotherapy, 6 patients intravitreal, 5 patients intraarterial, 2 patients received transpapillary thermotherapy, and only 2 patients received cryotherapy. Now, the total number of patients that were treated were 184, and there was a relapse in about 10%, 10 patients. Thank you so much.
आप आज डॉक्टर आसिम का फोल्डर मैंने पूरा फोल्डर दिया है मैंने आपको पूरा फोल्डर दिया है उसके लिए डॉक्टर आसिम की जो आपको
I'm Dr. Asim. Currently, I'm working in pediatric oncology at Pediatric Medicine Department, में Hospital Lahore. Well, I'm working here under the kind supervision of Professor Dr. Harun Ahmed and Professor Dr. Iftihar Ijaz. So I did my fellowship training from the Shaukat Hanam, and I'm working here from the last almost 5 years. We are trying our best to treat with the for the kids of retinoblastoma with very limited resources and few chemotherapeutic agents availability. So currently I'm here to tell what we are doing at our setup for the treatment of systemic chemotherapy in retinoblastoma. So we are using PSPO guidelines for the retinoblastoma treatment. So usually we receive patients from the pediatric ophthalmology department through a written call at our inpatient department. When the patient arrives, patient usually had a report of EUA, MR, and B scan. And most of the time, EUA report contains international intraorbital retinal blastoma staging classification written on it. So after accepting the patient, we admit the patient on our floor for the thorough history and systemic examination. So after this, we send baseline labs, and for the further staging workup, we do CSF and bone marrow. आगे नहीं जा रहा है। अच्छा। So, चलिए चलिए ठीक है, thank you. ठीक है. So after all this workup, we get to know whether the retinoblastoma is intraorbital or extraorbital. So most of the time before the start of treatment, I counsel the attendants myself about the prognosis, outcome of the disease, and side effects of benefits of the chemotherapy. So I usually had different scenarios which can vary patient to patient. Usually, I want to salvage the eye and save the life as well, most of the times. And sometimes I know the salvaging the eye is not possible. So we want to save the life of the patient. And in third scenario, the patient has already been progressed and presented to us with the progression of disease either or relapse of the disease. So we are using the further guidelines in case of unilateral intraorbital retinoblastoma. So there are stages as per intraorbital retinoblastoma classification. It could be stage A, B, C, D, or E. In case of A, we are using only local chemotherapy. So in case of B, we are using two drugs, which is carboplatin and vincristine. So in case of C, D, and E classification, we are using three drugs, 6 cycles with focal chemotherapy in some cases of C. But in D and E, we are using combined systemic chemotherapy and focal chemotherapy. As in group D, most of the patient, more than 50% patient can relapse. So we initially counsel the patient about the outcome of the disease and possible progression of the disease. So if the attendants are willing to take the chance, we will continue to give systemic and intraarterial chemotherapy in group D as well. And in group E, most of the times, if there is no optic nerve involvement, we will try to do upfront enucleation to save the life, and later on we will give systemic chemotherapy. So the status of radiation depends upon the optic nerve involvement in histopathology report or imaging. So if the resection margins are positive, we will give radiation afterwards. We are sending our patient to Anmol Hospital for the further radiotherapy of the patient. So in case of bilateral intraorbital retinoblastoma, we are using the same guidelines. However, we will follow the treatment for the worst eye, and we will try to salvage the one eye and to save the life of the patient. So this is the protocol. The length of the cycle is 21 days, and we are using carboplatin with 600 mg per meter square, vincristine with 1.5 mg per meter square, and toposide with 300 mg per meter square. And obviously, if the CSF is positive, we will give cytarabine intrathecal form on day 1. And for the patient having age less than 1 year or weight less than 10 kg, we will give 75% of the dose. So in case of extraorbital retinoblastoma guidelines, the same EUA page has details on it as the patient refer to us from the eye department. So in case say stage 3, if there is regional extension like lymph node involvement, or there is orbital involvement or overt orbital disease. And in case there is stage 4, the patient might have bone marrow metastasis, brain metastasis, or combined metastasis. So in stage 3, we are also using Joe chemotherapy with or without thecal cytarabine depending upon the status of CSF. But you can see we are using same chemotherapy in a bit higher dose than we are using in the intraorbital retinoblastoma. So this is the flow sheet. If a patient with retinoblastoma is presented to us with ocular tumor extension, we will give initially 3 cycles to debulk the tumor, and we will reassess the patient. And if in extraocular component regress, we will continue the chemo further and try to do the surgery as easy as possible. So after 4 to 6 weeks of surgery, we will give radiation and we will complete 12 cycles of chemotherapy. But in case if extraocular component did not regress, we will do orbital exenteration and later on give radiation and to complete the 12 cycles of chemotherapy. So we are doing palliative chemotherapy since we don't have the privilege to use the second line chemotherapy due to limited resources. So if any of our patient relapses or the patient has already been progressed, we are using low dose radiation plus Joe chemotherapy. So for therapeutic radiation, we are giving 40 gyra in 20 different 20 doses. And for palliative radiation, we are giving radiation at a low dose. So that's it. Any question you can ask. मैडम वो हम बेसिकली इधर म्यो में तो नहीं हो रही है अनमोल में भेज रहे हैं थेराप्यूटिक रेडिएशन फॉल्स इन द फ्रैक्शन ऑफ 40 गायरे इट्स नॉट माय फील्ड बट आई नो इट फॉर थेराप्यूटिक रेडिएशन 40 गायरे टोटल डोज होती है 20 डिवाइडेड फ्रैक्शन में दी जाती है
There's bilateral retinoblastoma with surgery has been done on one side and group B on the other side. So how will you treat that?
So it depends upon the status of the surgery eye. We will see the histopathology report. Obviously, we will try to salvage the group B eye with systemic chemotherapy first and follow the patient with regular.
You said that you will use like two agents.
Yes,
Vincristine
yes.
and not use rituximab.
But if the optic nerve, I have already told, we will follow the treatment for the worst eye in case of bilateral. So if the group E, we will try to follow.
Probably begin with all 3 agents.
Yes, yes,
And then
yes.
Labs की क्या cause है आपके experience में?
To be honest, in our setup, there is no proper follow-up. Even we have the numbers, phone numbers of the patient, address. When they do not come to us, we ourselves call them to come for follow-up checkup and chemotherapy. It happens many times that the patient did not have his chemotherapy cycle for 2 months, and then afterwards we call the patient to come for the chemotherapy, probably due to poor follow-up and close follow-up is not possible in our setup, I think. I'm trying to do it, but I don't think so it's possible.
For example, in case of group D and EI, they don't agree to us.
Yes.
And in fact, we have to go for chemotherapy first and we decide for surgery quite later on. That is one of the major causes that they come again with relapse.
Most of the times we try to do surgery before chemo, but in some patients, yes, in some patient when surgery has been delayed, obviously the chances of relapses are more. But in these cases, we are already counsel the patient about the outcome of the disease. It depends upon the will of the patient. So, but there are 2 or 3 patients of group D, Dr. Shumana knows very well, who responded to chemotherapy and intraarterial chemotherapy, and they are in remission. Group D, yes. But as being a pediatric oncologist, I will try to convince the ophthalmology team to do enucleation.
Reflection, yes.
Yes,
I agree with you.
yes. See, anything else? Okay, thank you.
Thank you so much, Dr. Asif. Ladies and gentlemen, retinoblastoma is a force to be reckoned with. It presents a diagnostic dilemma at times. Our first section of today's symposium will be pertaining to the diagnostic challenges that arise when diagnosing a patient of retinoblastoma. In this pretext, first of all, I'll invite on stage none other than Professor Dr. Asad Aslam Khan, who will expound on the topic that not every acute proptosis in a child is to be considered a retinoblastoma. Professor Asad Aslam.
Bismillahirrahmanirrahim. My presentation is not very high-tech presentation. This is a basic presentation, basically addressing the postgraduate and the residents and the house officers who come across a patient, a child with acute proptosis. And they are often confused what to label this patient: orbital cellulitis, retinoblastoma, rhabdomyosarcoma. And many a time in my professional career, twice it happened that the patient was put for exenteration, whereas it was not a case of retinoblastoma. So I thought it's very important to tell the residents how to work up a case of acute proptosis in a child. We have a large series of orbital lesion Institute of Ophthalmology, Mayo Hospital, K Medical University. We have series of 50 cases of orbital lesions starting from 1996. Before that, there was a series of more than 1800 cases by Professor Muhammad Mirul Haq Sahab till when he retired in 92. I basically started orbit after 92 when he retired. So in our series of 50 cases of orbital lesions, this is not retinoblastoma, orbital lesions, 42.5% cases were seen in children and 47.5% in adults. And if we talk about retinoblastoma, so in our series of 2650, so 99.6% of the ocular lesions were retinoblastoma in children. And if we talk about a total series, both in adults and children, they constituted 91.17%. And 41.1% of the orbital lesions in children, they are retinoblastoma. And 20.5% of the total orbital lesions in adults and children, it is retinoblastoma. So this is the percentage of retinoblastoma in a large series of orbital lesions. Now for the resident, just to make understand that there are different modes of presentation of retinoblastoma. A child may present to you with the leukocoria, white fever. This is the most common manifestation, presentation, if the patient comes at early stage. But we all see that the patient do not come at early stage. They come to our teaching hospital after visiting each and every place in the rural area. They go to Hakim. They don't leave any person before coming to a teaching hospital for retinoblastoma. The child may present with red eye, uveitis. You can see a hypopyon in the anterior chamber. So this is a second mode of presentation. Strabismus. So don't take every strabismus as a case of simple strabismus where you can treat either by prescribing glasses or by surgery. So think of strabismus in a child with sudden onset of squint. The parents bring the child that the child was fine, but for the last 2 weeks, we have noticed that his or her eye is squinting. So every child who has strabismus must undergo a complete ophthalmic examination to rule out retinoblastoma. So this was a child, was brought to our Institute of Ophthalmology, Mayo Hospital, way back in 97. We were brought with the presentation of squint. And when we worked up, it turned out to be case of retinoblastoma. Then these are the most common presentations. This is the most common presentation because they come very late. Late cases with orbital invasion present either with proptosis or they may present with fungating mass. Look at this child. This was a case seen in 2000, 99 case. It was associated with xeroderma pigmentosa. So these are the different modes of presentation. The case may present with spontaneous regression. In one eye, there is spontaneous regression. You can see on this is a case of retinoblastoma with spontaneous regression in the eye. But why I'm making this presentation for the resident, that not every child with proptosed eye, surfing cornea, and orbital involvement is a case of retinoblastoma. Other lesions like vascular, cystic, and inflammatory may behave and mimic retinoblastoma in their presentation. Proceeding without proper investigation may lead to enucleation, exenteration, thereby loss of the precious eye. Look at these 4 cases. As a house officer or postgraduate resident for first year, second year, I may took all cases as a case of retinoblastoma. So I will put them straightway for exenteration. But look at this. If we investigate this case, this is a case. You can see in the CT scan, eyeball is full of tumor. But this looks like another case. This looks like retinoblastoma. And this was a case. It was year 2001. It was put on the list for exenteration. And when we investigated, look at the CT scan. Eyeball is clear of any lesion, whereas there is a lesion in the retrobulbar area. We opened it and there was a large hematite cyst. Probably this patient had some trauma. The children, they do not usually tell that they had trauma. They go out, had trauma, have trauma, come back, and next, after a few hours, they start having proptosis. So this turned out to be a case of traumatic hematoma. And this was the same case after a few years. So proper investigation has saved the eye. So not every case, every child with acute proptosis is a case of retinoblastoma. We must investigate thoroughly. So for differential diagnosis of acute proptosis in a child, we must keep in mind orbital cellulitis, retinoblastoma, rhabdomyosarcoma, hemorrhage in lymphangioma, orbital hemorrhage, hematite cyst, blue cell tumor, sarcoma, and acute myeloid leukemia. So this is a list of acute proptosis in a child with proptosis, invaded orbit, and sloughing cornea. This orbital cellulitis, hematite cyst, extracorneal hematoma. It looks like a advanced case of retinoblastoma, but it was a case of extracorneal hematoma. Rhabdomyosarcoma, mimicking retinoblastoma. Blue cell tumor, acute myeloid leukemia. This was the case of year 2005. So my message basically is for the whole series, all the cases I have shown, they were dealt at Institute of Ophthalmology, Mayo Hospital. So my purpose was to tell the resident that work up the patient of acute proptosis in a child properly so that we can save the precious eye of the patient. Thank you very much.
Ladies and gentlemen, hence proof that when it comes to retinoblastoma, being thorough is the key. A holistic approach will ensure the safety of your patient. Ladies and gentlemen, let's hear it from Dr. Shabana Chaudhary.
Assalamu alaikum and good morning, everyone. Not all the battles are the lost ones. But to diagnose a retinoblastoma, we need a holistic approach to target the bullseye. I'm Dr. Shabana, Assistant Professor Pediatric Ophthalmology, Mayo Hospital. Let's start. Looks can be very deceiving. Here is the example. We start with the case, a 7-year-old girl who presented to us in 2018. She had a history of traumatic endophthalmitis, managed with multiple intravitreal antibiotics a year before, presented to us in 2 different institutions in Lahore. After 1 year, child was presented in pediatric ophthalmology facility in Mayo Hospital in June 2018 with the thiatrical eye. We did the B scan and there was a few identifiable specks of calcification that were at that time being suspected as because of the phthisis. The outcome of all the exercise was patient got lama, left against the medical advice. After a few months, patient presented again with CT brain report in her hand. And it was mentioned in the report that went without giving history to the duty doctor. CT also confirmed multiple internal specs. And there was preceptor cellulitis as well. And CT suggested of suspected case of retinoblastoma. We arranged EUA. Luckily, patient stayed with us for the examination under anesthesia, but then patient got lama again. Because someone from us told mother, eye small, cancer has died. No intervention required. Come for B scan when, if only convenient. Patient came in 2019. There was thiatrical eye. Patient didn't reach the consultant OPD. In March 2019, again the same condition, but in July, patient presented with acute proptosis of 15 days history. So the learning objective. in this presentation was we able to learn the key points in history taking in a retinoblastoma suspect child, determine the salient steps in ocular examination, and grasp the importance of multidisciplinary approach required to reach the diagnosis. Here, another case, 18-month-old girl brought in OPD with small right eye, noticed by mother for the last 6 months. So these are the questions for the audience, please. What have you observed in this pic? Make your own differential diagnosis. What history questions comes to your mind you would like to ask? What examination would you like to do in your OPD? And what investigation would you plan? Anyone, would you like to refer the patient to any other team? Again, the second case, 2-year-old girl presented with something shining in the right eye since 3 months. Same questions. Make up your mind, guys and ladies, please. So, in case 1, what causes the phthisis bulbi? You must have your own differential diagnosis. In case 2, what was the causes of white pupil? It could be cataract, it could be retinoblastoma, it could be coarse disease, ROP. So in case 1, in history, age of onset is important, nature of onset is important, duration is important to know. History of trauma or surgery is important to know. And again, we need, as we don't have the genetic testing here, but we can do the clinical testing, genetic analysis. Sorry. So pedigree of the patient is important. Make the pedigree. Here is the patient who had a family history of retinoblastoma positive. Mother. So in clinical examination, how to proceed now? It's not working. Sorry. Okay. So the visual acuity of the patient. Video see can go on the you can take some bed. दूसरी पहले फर्स्ट वाली नीचे जाएं चलें ऑन करें okay let's move on. So in examination we'll examine the visual acuity, we'll examine the pupil for RAPD, we'll do the intraocular pressure and then slit examination of a child. We'll examine the adnexa and slit lamp for any hypopion. Okay. One second. Andy, please. Thank you. Okay. So we'll do the examination. We'll do the okay. Just give me 1 second. There's a video we are trying to manage to start.
Ladies and gentlemen, when diagnosing retinoblastoma after a thorough history and examination, our first course of action, of course, comes to imaging. Magnetic resonance imaging is of much import here. Ladies and gentlemen, we are lucky that we have a diagnostic virtuoso with us here today, in whose hands MRI comes to life like no other. I request Professor Dr. Abid Ali Qureshi to please join us on stage and expound on MR imaging in retinoblastoma.
Better pointed. Yeah, thank you, organizers and everyone, for giving me the opportunity to share my experience in cases of retinoblastoma. So my main discussion is the role of imaging when it comes to the retinoblastoma. We have actually the three options available when it comes to the masses, orbital masses in small children. The available options, as far as the imaging are concerned, is ultrasound, CT scan, and MRI. And out of these three, we have to think judiciously and according to the patient's requirement. As far as the no doubt, the examination under anesthesia combined with ultrasound and MRI is the very useful imaging methods for specifically not for the confirmation of diagnosis, but to see the extent of the disease as well. In general, apart from the retinoblastoma, every head and neck tumors, we come across these three investigations. Ultrasound particularly is very important for the superficial masses. And this one, which we are discussing right now, retinoblastoma, is one of the superficial mass, which primarily involves the eyeball. And ultrasound is useful not only to characterize the mass, but also to see the calcifications and other associated extent. But to some extent, this has some limitations regarding its extent to involvement of the optic nerve and the status of the choroid as well. And when it comes to the CT and MRI, it is very useful whenever we want to image the deeper structures. Apart from the eyeball, when it comes to the spread of the disease, the status of the optic nerve, the choroid, the adjacent bony orbit, and to the brain as well, then it will have to be some other modality other than the ultrasound, and that includes both CT and MRI. And nowadays, we are not using CT scan as one of the routine modality, and minded that this was the only available modality about 2 to 3 decades ago. When there was nothing available, the CT was the only hope at that time. And there were certain features which were diagnostic for the retinoblastoma and helps to differentiate it from the other conditions. Lots of other interesting cases are shared by Professor Dr. Asad Aslam, that how the CT was playing an important role in that period. But these days, why MRI is considered much superior compared to the ultrasound and CT scan? There are some specific advantages. Number one is the soft tissue contrast. MR has inherent capability because that shows the different constituents of the fluid and the solid cells. So the water to cell ratio is better picked up with the help of MRI. So soft tissue contrast is always better than the CT scan or the other available imaging modalities. And the other disadvantage is multiplanar capability. We are capable of seeing the same location of the mass with axial, sagittal, and corner planes. Same can be done with the modern available CT scanners, but CT scanners are not used because of the radiation risk. वो मैं आपको अभी explain करूँगा. The third point, the most important point, is the lack of ionizing radiation. CT uses the ionizing radiation, and specifically the eye, the lens, and the rest of the structures in the children, they're more radio sensitive. So we should avoid the use of CT scan, in spite of the fact the CT gives many useful information. And the fourth advantage point is the acoustic shadowing. What does the acoustic shadowing mean? The people who are involved in ultrasound might have the best, better knowledge. Whenever there is some error born in between the area which is being scanned, that lead to certain artifacts. So in certain situations, acoustic shadowing becomes a problem, specifically while doing ultrasound. So two important points, the soft tissue contrast capability and the lack of ionizing radiation gives the MRI a superior edge compared to the ultrasound and CT scan. Acha, mind it, the most important thing by writing the MRI brain or MRI orbit is alone not a sufficient word. We will discuss what actually we need to have a good quality MRI in cases of retinoblastoma. Apart from the, when we talk about the higher resolution means more thinner the slices. Usually brain imaging protocol are of 4 millimeter with a gap of 4 millimeter. So we will we used to get a sufficient number of images in a routine imaging protocol. But when it comes to the orbit, we have to take more thinner slices with no gaps. So we will have more detail. And to get that much level of detail, we need a certain specific hardware. MRI has advantage over the other investigations is the involvement of the optic nerve and the extraocular extension and intracranial disease as well. Whenever we talk about the MRI of the orbit, we always combine imaging with the routine image of the brain as well to look for the other areas where this type of disease that you have might have knowing the laterality of the disease. Trilateral disease can only be diagnosed when the brain images become the integral part. What would be the imaging strategy? No doubt, examination under anesthesia with fundoscopy and ultrasound, they usually make the diagnosis. But confirmation of the diagnosis and to see the further details, we need to have MRI. Why don't we consider CT scan as the ideal investigation? Why 2-3 decades ago, this was the only modality available? Just because the CT has got the more radiation effects. No doubt the CT has the biggest advantage to identify the calcification. And still now, calcification are best seen with the help of CT scan compared to the ultrasound and MRI. Now, thanks to the technical advancement in the equipments, today the type of equipments in the shape of ultrasound and MRI, they are equally good in detecting the calcifications, needing the expertise and the type of imaging. अगर आपकी imaging बहुत अच्छी है, तो then definitely MR will tell you the presence of calcification. Only a selected number of cases, CT is being selected when diagnosis becomes ambiguous and in spite of having ultrasound, retinoblastoma, the diagnosis is still in question. You can choose the CT scan, but only in the selected cases. So recently, there has been a study that shows the importance of MRI, specifically these T2 weighted sequences. Whenever we talk about the MRI, you might have heard the different names. The T1 and T2 are the mainstay of every MRI. And apart from some other development of software techniques, we can devise the various other sequences to improve the diagnostic capability. No doubt the retinoblastoma, we're talking about the retinoblastoma, but MRI helps to differentiate the other causes of leukoplasia. So in the descending order, we can easily diagnose THPV, Coats disease, and their toxic areas of retinopathy of the prematurity, and other diagnoses as well. Remember one thing, that this is not the case of retinoblastoma. MRI helps to differentiate this diagnosis with other common differentials and to diagnose the other common infective processes and other orbital tumors. As far as the tumor extent detection is concerned, in the past, I've already told you that CT was the mainstay. But CT was not able to tell you the involvement of sclera, choroid, and specifically optic nerve involvement was very difficult to pick on the CT scans. But now, because of the MRI, because of its better soft tissue capability, we not only have the better tumor extent knowledge, but also the metastatic survey and the involvement of the rest of the brain. We can have an accurate diagnosis by using the tools of MRI. And how we can standardize the retinoblastoma? The biggest problem as far as the standardization is concerned, remember one thing, every patient is a different patient with each other, and we have to plan imaging customized to that particular child. Specifically, the biggest problem is the sedation. And obviously, there is some in public sector hospital, there always been have a problem because there's no dedicated anesthesia facility available in MRI suite. And specifically, then we have to rely on the oral and IV contrast. And at times, oral and IV contrast turned out to be not very useful. So ideal situation in descending order, best is that do this these scan with the general anesthesia, because that will also control the movements of the eyelid. I will explain the recommended protocols. And I have pointed out one of the recommendation from the European Retinoblastoma Imaging Collaboration. They say that you have to carry imaging of retinoblastoma in a dedicated imaging setup. When we talk about the dedicated imaging setup, means availability of all concerned specialties, specifically anesthesia. Along with anesthetist and the other team members, we can enhance the results of these MRI. Second most important thing, the coils, system and coils. As far as the system is concerned, there are lots of MRI available in public and private sector. One is the open MRI, another one is the closed magnet. We need to have a higher Tesla MRI. Higher Tesla MRI means at least 1 Tesla. So practically all public sector hospitals, they are having 1.5 Tesla MR system, and there are further 3 to 4 subtypes of 1.5 Tesla MR system. So currently every public sector hospital is having a very higher power of these magnets and making a more capable of imaging of these masses, having more detailed information compared to the open MRI. Open MRI, mind it, this is not the ideal hardware for the imaging of retinoblastoma. मैं आपको उसके थोड़े से images हैं वो भी share करूंगा. एक टेस्ला important है, दूसरा आपकी कॉइल. इस ध्यान में रखिए, MR का basic function मैं आपको बताता हूँ how it works. Magnetic waves that pass through the body and that causes the movement of the protons within the nuclei. And that movement of the proton is detected by the external antenna. One component is the strength of the magnet, another component आपका जो receive करना है channel वो भी बहुत important है. तो head coil, मैंने यहाँ एक लफ्ज लिखा है जो रेडियोलॉजी के कोलीग्स अगर हैं तो वो समझ सकते हैं कि मल्टी चैनल कॉइल क्या होती है. मल्टी चैनल कॉइल ये कि आपका सिस्टम 16 चैनल या 32 चैनल है और आपकी कॉइल 4 चैनल है, तो ये सिंक नहीं हो पाएगी, आपको गुड एसएनआर नहीं देगी. सिग्नल टू नॉइज रेशियो इज द मेन स्टे ऑफ द गुड क्वालिटी एमआरआई. हमें हाई एसएनआर लेना होता है, इंप्रूविंग द मैग्नेट पावर को इंप्रूव करे और कॉइल बेहतर. Every public sector hospital, at least they do have 8 to 16 elements coil. किसी भी public sector hospital सिर्फ उसको एक्टिवेट करना पड़ता है. अब जो कॉइल नहीं आ रही हैं वो 20 एलिमेंट्स की भी आ रही हैं, तो सिर्फ यहाँ ये डिबेट इसलिए डिस्कस करने की जरूरत है. डोंट प्रेफर ओपन एमआरआई सिस्टम इन केसेस ऑफ रेटिनोब्लास्टोमा. वो चाहे ओपन है, यूजर फ्रेंडली है, लेकिन उसकी वो क्वालिटी इमेजिंग नहीं है जो 1.5 टेस्ला की आती. दूसरी एक इंपॉर्टेंट डिस्कशन है कि 1.5 टेस्ला में इसके अलावा एक तीसरी एडिशन है जो कि यूजुअली अभी तक हमारे किसी सेटअप में नहीं है. वो है कंबाइन आफ्टर द हेड कॉइल. आप आई के ऊपर भी कॉइल रख सकते हैं, बट आई के ऊपर कॉइल रखने के लिए दैट मस्ट बी ऑफ द सेम साइज. छोटे बच्चे होते हैं, अब हम इसको कहते हैं फ्लेक्सिबल कॉइल्स. गोल कॉइल्स होती हैं, सर्कुलर कॉइल्स होती हैं, इसके डिफरेंट साइजेस होते हैं. यूजुअली स्टैंडर्ड जब आपको ये कॉइल्स सप्लाई होती हैं तो कोई भी ऑर्बिट के कॉइल को प्रेफर नहीं करता. बट आई वुड रेकमेंड कि किसी भी ऐसे सेटअप में जहाँ पीडियाट्रिक ऑन्कोलॉजी है, जहाँ रेटिनोब्लास्टोमा का इंसिडेंस बहुत ज्यादा है, वहाँ दीज कॉइल मस्ट बी ब्रॉट विद द एमआर, क्योंकि आपको एमआर के सिस्टम के साथ जो रिक्वायरमेंट जनरेट करनी होती है इस कॉइल की कोई उस वक्त वैल्यू नहीं होती. लेकिन अगर आप सेपरेट बाय करेंगे तो दैट विल हैव द कॉस्ट इम्प्लीकेशंस. अब 3 टेस्ला भी आजकल सिस्टम लाहौर में 2 जगहों पर 3 टेस्ला अवेलेबल है. अब 3 टेस्ला और 1.5 टेस्ला की डिबेट में एज फॉर इज द इमेजिंग ऑफ रेटिनोब्लास्टोमा इज कंसर्न देयर इज नॉट मच डिफरेंस. 3 टेस्ला की अभी स्टडीज हो रही हैं. 3 टेस्ला में थोड़े से कुछ इश्यूज हैं. प्री मैच्योर बेबीज के लिए 3 टेस्ला इज नॉट रिकमेंडेड. तो माइनट in that particular age group we can have this disease. तो premature brain के लिए 3 Tesla is not recommended या अभी उसकी studies prove नहीं हुई है. So that's the main reason कि आपको pediatric imaging के लिए if you have the 1.5 Tesla imaging that is sufficient. ये एक पिक्चर सिर्फ मैंने कॉइल्स दिखाने के लिए आपको, ये हेड कॉइल है, मल्टी चैनल हेड कॉइल है, लेकिन इसके साथ आप एक छोटा सा राउंड कॉइल देखिए. दैट कॉइल इज प्लेस्ड ओवर द लेफ्ट ऑर्बिट. अब ये कॉइल प्लेस करने के कुछ एडवांटेजेस भी हैं और कुछ डिसएडवांटेज भी हैं. अगर तो प्रोप्टोज्ड आई है, पेशेंट पेन के अंदर है, तो देन डेफिनेटली आप कॉइल प्लेस करेंगे तो मूवमेंट आएगी. लेकिन यहाँ मैंने शुरू में एक बात आपको की थी कि आइडियल सिचुएशन ये है कि आप एनेस्थीसिया में एमआरआई को करवाएं. अगर आपने ओरल या आईवी सेडेशन दी तो देन मोशन ब्लड जो है ना विल हैम्पर द इमेजेस. नो डाउट द अवेलेबिलिटी ऑफ सरफेस कॉइल्स अगर हैं तो आपकी डायग्नोस्टिक कैपेबिलिटी बढ़ जाती है, लेकिन अगर आपके पास अननोन मल्टी चैनल हेड कॉइल मौजूद है तो दैट दिस इज सफिशिएंट टू गेट अ गुड क्वालिटी इमेज. These are the names of sequences which we usually perform while imaging the orbit, specifically when it comes to the retinoblastoma. T2 एक रूटीन सीक्वेंस. सिर्फ फर्क क्या है कि इसकी स्लाइस थिकनेस 2 मिलीमीटर या लेस होनी चाहिए, और T2 मिलीमीटर कभी भी आप अटेन नहीं कर सकते विद द ओपन एमआरआई सिस्टम. दिस इज द बिगेस्ट डिसएडवांटेज. आपको 1.5 टेस्ला और या हाई स्ल्यू रेट इज वन ऑफ द टेक्निकल पैरामीटर ऑफ एमआरआई. आपको एक क्वालिटी के इमेज देने के लिए या तो ये स्लाइस थिकनेस इतनी करनी पड़ेगी, या स्पेसिफिकली ये सीक्वेंस के नाम है, ये भी T2 की वैरायटी है. द स्कैनर हियर व्हिच इज बीइंग इंस्टॉल्ड एट मेयो हॉस्पिटल, उसमें इसका नाम फिएस्टा है. अगर यहाँ पर हमारे कुछ कोलीग्स हैं, और द सिस्टम जो फिलिप्स बाकी जगहों पर लगा हुआ है उसमें ड्राइव. दीज आर द बेसिकली स्पेसिफिक T2 इमेजेस प्रोटोकॉल व्हिच हेल्प्स टू गेट द गुड क्वालिटी इमेजेस. बाकी रेस्ट ऑफ इमेजेस में सबसे इंपॉर्टेंट पॉइंट है प्री एंड पोस्ट कॉन्ट्रास्ट फैट सप्रेशन, बिकॉज ऑप्टिक नर्व के इन्वॉल्वमेंट हम फैट सप्रेशन सीक्वेंसेस के बगैर अच्छा नहीं देख सकते. एंड द मोस्ट अदर पॉइंट इज द इमेजिंग ऑफ द ब्रेन अपार्ट फ्रॉम द रूटीन और इमेजिंग ऑफ द ऑर्बिट. अच्छा, रिपोर्ट करते वक्त किन पॉइंट्स को हमने ध्यान में रखने, एक है ट्यूमर कैरेक्टराइजेशन और दूसरा है उसकी एक्सटेंशन. ट्यूमर कैरेक्टराइजेशन में ऐसा ही मीन सिग्नल इंटेंसिटी, हम उसको एमआर के अंदर कोई भी ब्राइट या डार्क लुकिंग, हम उसको अपनी टर्मिनोलॉजी में सिग्नल्स बोलते हैं. द डार्क लो सिग्नल मीन्स के ब्लैक लुकिंग, हाई सिग्नल मीन्स व्हाइट लुकिंग. बाकी उसी की एक्सटेंशन की बुनियाद के ऊपर इमेजेस को देखा जाता है. दिस अपीयर्स bright on T1 and low on T2. This is the main feature of retinoblastoma. बाकी ऑप्टिक नर्व इन्वॉल्वमेंट, ऑप्टिक नर्व शीथ इन्वॉल्वमेंट को विदाउट कॉन्ट्रास्ट हम कमेंट नहीं कर सकते. तो इसमें एवरी इमेजिंग इज बीइंग डन विद द कॉन्ट्रास्ट. ये कुछ इमेजेस हैं जो आपसे शेयर करने हैं. दिस इज T2 weighted image. T2 weighted image की पहचान ये कि फ्लूइड अपीयर्स ब्राइट इन अ नॉर्मल विट्रियस. यहाँ अगर आप देखें कंपेयर टू द विट्रियस, दिस इज ब्लैक एरिया, लो सिग्नल एरिया इज द रेटिनोब्लास्टोमा. यहाँ एक एडिशनल फाइंडिंग है कि लेंस की डिसलोकेशन है, लेकिन कोराइड एपरेंटली ठीक लगती है. ऑप्टिक नर्व इस इमेज पर बजाहिर हमें कोई एबनॉर्मलिटी लग नहीं रही, लेकिन ये रखें कि ये सीक्वेंस इज नॉट सफिशिएंट टू कमेंट ऑन ऑप्टिक नर्व until unless we go for the post contrast study. Now look at these images. यहाँ पर ये प्री कॉन्ट्रास्ट है. प्री कॉन्ट्रास्ट मीन अभी कॉन्ट्रास्ट नहीं लगाया. मैंने शुरू में आपको बताया कि ये T1 के ऊपर हाई होता है, लेकिन ये कुछ ज्यादा हाई है. इतना हाई T1 के ऊपर या ब्लड होता है या हेमरेज, वो सॉरी, या कॉन्ट्रास्ट होगा. जब कॉन्ट्रास्ट नहीं लगाया तो यूजुअली कुछ केसेस में हमें ट्यूमर के अंदर हेमरेज में मिल जाते हैं. तो दिस इज हेमरेजिक मास. पोस्ट कॉन्ट्रास्ट माइल्ड से एनहांसमेंट आपको नजर आई. अगेन T2 कॉर्नर और सैजिटल इमेज, इसमें हमें पोस्ट कॉन्ट्रास्ट में कोई ऑप्टिक नर्व की इन्वॉल्वमेंट नहीं मिलेगी. तो दिस वाज द केस ऑफ यूनिलैटरल रेटिनोब्लास्टोमा. अनदर केस अगेन T2 लो सिग्नल एबनॉर्मलिटी इन द लेफ्ट आई बॉल, थोड़ी प्रोप्टोसिस हुई हुई है. अब आगे देखिए, यहाँ पर देखिए कि इस जगह पर ये रेट्रोबल्बर स्पेस इज मच क्लियर, while on the left side there is some dirty appearance of the retrobulbar space, and here you can see the very significant thickening of the optic nerve, and optic nerve उसकी entire extent में thickened and there is a mass in the suprasellar region. So वो डिजीज की एक्सटेंशन इतनी बड़ी है कि वो क्याज़्मा तक चली गई है. पूरा उसने ऑप्टिक पाथ को फॉलो किया है. अब यहाँ दूसरा एक ओके, दिस इज द पोस्ट कॉन्ट्रास्ट. अब यहाँ देखिए, ये पोस्ट कॉन्ट्रास्ट फैट सप्रेशन है. यूजुअली रेट्रोबल्बर रीजन में फैट ब्राइट नजर आती है, बट दिस इज ब्लैक एंड दिस एनहांसेस द कैपेबिलिटी ऑफ सीइंग द लोकल एक्सटेंट ऑफ द डिजीज. So again, optic nerve involvement है, optic chiasm तक involvement है. So these are the images which we get with the use of surface coils. ये वो एक ऐसा component है which we are lacking in at least in Punjab. चंद certain dedicated centers we're trying to get, लेकिन हमारे पास जो circular coil है वो इतनी बड़ी है कि वो पूरे face को cover कर रही है। तो छोटी सर्कुलर कॉइल जो है वो अलग हो तो आपको एक डेडिकेटेड ऑर्बिटल इमेज मिल जाता है। यहाँ थोड़ा सा प्रॉब्लम ये होता है कि लेटरलिटी ऑफ द डिजीज को देखने के लिए आप अगर एक को फोकस करेंगे तो एक आई का इमेज आएगा, या तो आप दो कॉइल्स यूज करें या आप इसको कंबाइन कर सकते हैं। अब टेक्नोलॉजी थोड़ी बेहतर हो गई है कि आपने जहां यूज करना हो आप हेड कॉइल को यूज करें और जहां आपने यूज करना हो उसी पोजीशन के साथ आप सरफेस कॉइल को भी यूज कर सकते हैं। बट द फाइंडिंग इज द सेम, द लो इंटेंसिटी मास with the retinal detachment on T2 weighted images. This is pre-contrast and this is post-contrast showing enhancement. यहाँ अगर आप देखिए पेरिफेरल रिम पे आपको कोराइड नजर आ रही है, ऑप्टिक नर्व नजर आ रहा है, बाकी इसकी एक्सटेंशन आउटसाइड द ग्लोब बजाहिर नहीं है। अब यहाँ मैंने एक बात की थी कि कैल्सिफिकेशन की कैपेबिलिटी सीटी की बहुत ज्यादा है, नो डाउट, बट जस्ट बिकॉज ऑफ दिस सुपीरियर कैपेबिलिटी हम सीटी को एक्वायर नहीं करते। रीजन मैं ऑलरेडी बता चुका हूँ, बिकॉज ऑफ द रेडिएशन रिस्क। यहाँ पर अगर आप देखिए सीटी पर कैल्सिफिकेशन ब्राइट नजर आती है और एमआरआई पर ये डार्क नजर आती है। तो मैस और कैल्सिफिकेशन को डिफरेंशिएट करना एट टाइम्स मुश्किल हो जाता है, और इन सर्टेन सिचुएशंस जब इक्विवोकल सी डायग्नोसिस हो और आप डायग्नोसिस तक ना पहुंच रही हो, सिर्फ उन सिलेक्टेड केसेस में सीटी को यूज किया जाता है, बट नॉट एज ए रूटीन मोडालिटी। दिस वाज द इमेजिंग टेक्निक फॉर द रेडियोलॉजी कोलीग्स कि हाउ वी हैव टू लुक फॉर द ऑप्टिक नर्व। जब तक आपकी स्लाइस प्लानिंग ऑप्टिक नर्व के पैरेलल नहीं होगी, आप ऑप्टिक नर्व की इन्वॉल्वमेंट कमेंट नहीं कर सकते। मैं आपको दिखाता हूँ अगले कुछ केसेस के अंदर। यहाँ पर देखिए मैस है, प्री कॉन्ट्रास्ट पोस्ट कॉन्ट्रास्ट, यहाँ आपको ऑप्टिक नर्व हेड बिल्कुल ठीक मिला है। इस अनदर मैस प्री एंड पोस्ट कॉन्ट्रास्ट, इसमें भी ऑप्टिक अच्छे। अब ऑप्टिक नर्व में 2 मिलीमीटर का एबनॉर्मल सिग्नल या 2 मिलीमीटर के एनहांसिंग फोकस इज कंसिडर्ड टू बी द इन्वॉल्वमेंट ऑफ ऑप्टिक नर्व, वो चाहे ऑप्टिक नर्व हेड पर हो या उसके प्रॉक्सिमल कोर्स पर हो। अच्छा, अब यहाँ देखिए कि अगेन मैस T2 हाइपोइंटेंस है, लेकिन इसकी क्लैरिटी क्या पिछले केसेस जैसी है या थोड़ी सी हैम्पर्ड है। हम रेट्रोबल्बर स्पेस को बहुत क्लियरली नहीं देख पा रहे। दीज आर द इमेजेस एक्वायर्ड एट ओपन एमआरआई सिस्टम। अब मैं बात कर रहा था ऑप्टिक नर्व शीट की। लुक एट द प्री कॉन्ट्रास्ट इमेजेस एंड लुक एट द पोस्ट कॉन्ट्रास्ट इमेज। अब प्री कॉन्ट्रास्ट पर ये ऑप्टिक नर्व हेड का रीजन है, यहाँ एक फोकल एनहांसिंग एरिया है। नो डाउट कि इसमें ऑप्टिक नर्व लीनियर सिग्नल हमें नहीं मिल रहा, लेकिन वो जो छोटा सा ऑप्टिक नर्व के ऊपर एनहांसिंग फोकस है सफिशिएंट टू मेक कंफर्मेशन दैट द ऑप्टिक नर्व इज बीइंग इन्वॉल्व्ड। So this is the beauty of MRI compared to the other like CT and ultrasound, कि हम उसकी local extent और extension को ज्यादा बेहतर तरीके से देख सकते हैं। This is another patient having optic nerve involvement. अब आ जाता है ocular wall invasion. These are the points which can only be seen with the MRI. यहाँ आप देखिए कि कोरॉइड आपको एक पेरिफेरल हाइपर इंटेंस बाउंड्री की सूरत में नजर आ, बट दिस एरिया इज इल डिस्टिंक्ट, सो mass is infiltrating the adjacent choroid. So this is also again a point which we can miss with the other modalities. Anterior segment of eye के अंदर अगर आप देखें तो post contrast images के अलावा हमें और कोई information नहीं मिलती। यहाँ अगर आप देखिए थोड़ा सा ये zoomed image है क्योंकि बहुत small structure है तो थोड़ा blur भी है, लेकिन अगर आप यहाँ देखें तो एक slight सा enhancing focus है that also shows the importance that the anterior segment is being involved. Other important point is the imaging of brain. हमेशा ब्रेन का इमेज चाहे आप T2 एक्सियल करें या पोस्ट कॉन्ट्रास्ट करें, रूटीन प्रोटोकॉल ये होता है कि एक T2 इमेज करें और एक पोस्ट कॉन्ट्रास्ट T2 करें। अगर आपको पाइनियर ग्लैंड में कोई एब्नॉर्मलिटी मिलती है देन गो फॉर द सैजिटल इमेजेस एज वेल। लेंथ ऑफ एग्जामिनेशन को सुपरवाइज तरीके से आप उसको शॉर्ट कर सकते हैं। दिस इज द एनहांसिंग फोकस एट द रीजन ऑफ पाइनियर ग्लैंड सजेस्टिव ऑफ ट्राइलैटरल रेटिनोब्लास्टोमा। दिस इज अनदर पेशेंट, मैस इन द लेफ्ट आई बॉल, ये प्लेन इमेजेस है T2 और सेम पेशेंट है। इंटेंस एनहांसमेंट अगेन फैट सप्रेशन टेक्निक यूज की गई है और यहाँ आप देखिए देयर इज अ स्मॉल नोड्यूल एट द रीजन ऑफ पाइनियल ग्लैंड, सो वन आई एंड द पाइनियल ग्लैंड इज इन्वॉल्व्ड विद द ट्राइलैटरल रेटिनोब्लास्टोमा। अगेन एनहांसिंग फोकस। ये दो एरियाज ऐसे हैं कि अगर आप रूटीन इमेजिंग नहीं करेंगे तो पाइनियल ग्लैंड मिस हो जाए। तो जब भी आपने MRI ऑर्बिट अगर लिखना है तो माइंडेड कि आपके रेडियोलॉजी कोलीग्स को ये अंडरस्टैंडिंग हो कि दैट डज नॉट मीन कि हमने सिर्फ ऑर्बिट करना है, आपको हमेशा ब्रेन इंक्लूड करना है। क्योंकि कुछ और एसोसिएशंस भी हैं, कंजेनिटल एनॉमलीज भी हो सकती हैं, तो आपको रूटीनली। अच्छा, अब आप देखिए दिस वन ऑफ द पेशेंट द पोस्ट ऑपरेटिव स्टेटस। पोस्ट ऑपरेटिव स्टेटस में द मोस्ट इंपॉर्टेंट क्वेरी इज द रिकरेंस। अब इस इमेज पर देखिए कुछ आइडिया होता है. Right eyeball there is surgically removed. There is some hypo-intense area over here. अब ये suspected सा area है. इसको जब तक हम post contrast नहीं करेंगे, we cannot identify. And here look at this shows intense enhancement. This shows intense enhancement. So that represents the recurrence of the disease. और एक ये भी एक ध्यान में रखिएगा कि प्री ऑपरेटिव स्टेजिंग इज मच मोर इम्पोर्टेंट. एट टाइम्स अगर आपकी इमेजिंग प्लानिंग एडिक्वेट नहीं है तो हो सकता है प्री ऑपरेटिव स्टेटस में ही ऑप्टिक नर्व इन्वॉल्व हो. तो दीज आर द वेरी इंपॉर्टेंट पॉइंट्स. ऑलवेज प्रेफर टू इमेज इन अ प्रॉपर वे, जो हमने अभी डिस्क्राइब किया कि प्रॉपर सिलेक्शन ऑफ हार्डवेयर एंड द सॉफ्टवेयर. अनदर पेशेंट, अब ये रूटीन मेथड के ऊपर किया गया है. इसमें अगर आप देखें तो ऑप्टिक नर्व हेड स्लाइटली इन्वॉल्व है, लेकिन चूंकि ये सिस्टम 1.5T नहीं है तो इसकी कुछ ब्लरिंग आपको नजर आ रही है. हालांकि अगर यहाँ देखा जाए तो जिसने भी ऑपरेटर ने कोशिश बहुत की है कि उसकी चीजें मिस ना हो, लेकिन ब्लरिंग जो है इट्स अ पार्ट ऑफ द, इट्स अ प्रॉब्लम ऑफ द मशीन. नाउ दिस इज द डिफरेंस. नाउ डिसाइड योरसेल्फ, आप ऊपर और नीचे के इमेज की क्वालिटी को फर्क देख सकते हैं एज फार एज द ऑर्बिट इज कंसर्न. आप इसकी क्लैरिटी देखें और इसकी क्लैरिटी देखें जो नीचे दिखाया. ये इमेज ओपन एमआर का है और ये इमेज सुपर कंडक्टिंग मैग्नेट या 1.5 टेस्ला का. तो जो एक्सटेंट ऑफ डिजीज है उसके लिए हार्डवेयर की सिलेक्शन हमेशा 1.5 एटलीस्ट होनी चाहिए. बाकी इमेजिंग प्रोटोकॉल मैंने आपको बताया. रेडियोलॉजी कोलीग्स यूजुअली दे आर ट्यून्ड टू हैव द प्रॉपर इमेजिंग प्रोटोकॉल. लेकिन अगर आपकी लेजोन बेहतर होगा तो 3 चीजें हैं जो प्रॉब्लम करती है. नंबर 1, अवेलेबिलिटी ऑफ एनेस्थीसिया. मतलब हम अपने डिपार्टमेंट में भी हमारा हमेशा प्रॉब्लम रहता है, हु इज गोइंग टू गिव द एनेस्थीसिया. तो अब आई डिपार्टमेंट, ऑन्कोलॉजी डिपार्टमेंट और हम तीनों के पास एनेस्थेसिस्ट नहीं होता. तो दिस इज द प्रॉब्लम व्हिच वी यूजुअली फेस. दूसरा इंपॉर्टेंट है सिलेक्शन. जस्ट एवरी पब्लिक सेक्टर हॉस्पिटल हैव 1.5 टेस्ला सिस्टम. थर्ड वन इज द सीक्वेंसेस. एवरी मशीन इज वेल इक्विप्ड विद ऑल दीस सीक्वेंसेस जो मैंने यहाँ बताए. किसी भी मशीन पर, चाहे वो पब्लिक सेक्टर में या प्राइवेट सेक्टर पे, सिर्फ उसको प्रॉपरली अप्लाई करना है. अदरवाइज इसकी जो यूजफुलनेस है वो मिस हो जाएगी अगर हम उन प्रॉपर सीक्वेंसेस को अप्लाई ना करें. सो इन शॉर्ट, as far as the no doubt ultrasound or examination under anesthesia is the main initial investigation, but MRI is for the diagnostic confirmation, to know about the tumor extent and to know about the other intracranial anomalies. और CT की अब जरूरत नहीं है, वो मैंने आपको पहले एक्सप्लेन कर दिया है. और इस वक्त अगर हम क्लिनिकल एग्जामिनेशन, अल्ट्रासाउंड और MR इन सबको कंबाइन करें तो देयर विल बी नो डायग्नोस्टिक डायलेमा. रादर वी विल बी हैविंग एन अपॉर्चुनिटी टू डिफरेंशिएट दिस रेटिनोब्लास्टोमा फ्रॉम द अदर नॉन रेटिनोब्लास्टोमा लीजन्स. थैंक यू वेरी मच. आई एम सॉरी, मेरे ख्याल है मैंने कुछ ज्यादा वक्त ले लिया.
Thank you so much, sir. It's always a pleasure listening to you. Ladies and gentlemen, we have discussed about history examination. We have discussed about the imaging. Now it's time for classification of the disease. To discuss about the classification of the disease and to present the latest updates regarding that, I'd like to invite on stage an ophthalmologist par excellence whose representation of Pakistan internationally makes us proud, whose work here at home is exceptional. Ladies and gentlemen, Professor Dr. Hussain Ahmed Khan.
Good morning, ladies and gentlemen. Thank you, Institute of Ophthalmology, Professor Muhammad Moeen and Dr. Shabana Chaudhary, Professor Ali, Professor Intezar Bhatt for kind invitation. I have been invited, I have been assigned for this talk. Can I have a slide changer? Okay. I've been invited for this talk and I've been assigned this topic that is very near to my heart. Retinoblastoma always been my preference in my career and in my ophthalmology. So I've been assigned to talk about the classification. I would like to have little bit attention about the classification. It's not that I can read this one. Anybody can read. Anyone who knows the English can read this one. These are just 6 lines. But behind these 6 lines, there's a lot of things. These are the words that cannot narrate the disease. You should try to understand one thing. Retinoblastoma has not read our ophthalmology. Believe me. We have read the retinoblastoma in ophthalmology book, but retinoblastoma has never read our ophthalmology book. So keep it in mind. So these are the text words, and they convey a very little message. They convey not more than a text, less than 3 millimeter, more than 3 millimeter diffuse seed, that's all. Because none of the classification cannot overcome the clinical picture that you should know. This classification is important, and it's important because all the things that we are talking today about the MR, about the B scan, about the treatment, about the radiotherapy has nothing to do until unless you don't hit the bullseye over here. And believe me, this is the most difficult place. Believe me. Still, I am working for the retinoblastoma more than 16 years. Sometimes I am still confused. And I never examine a patient of retinoblastoma without anesthesia. Please stop examining the patients of leukocoria with holding their head by the PN and examining with the indirect ophthalmoscope. This is just a message. Please take it seriously. Every patient with leukocoria should go for examination under anesthesia. Even you are 100, 200% confirmed that it's a cataract. Then even you should go with. This is once for life. If you will keep on doing this, in 120 cases you will miss, and they will be retinoblastoma. Believe me. So it's very important. Regarding the classification, the first thing, how these things can narrate in the eye until unless you are not going to examine in a comfort zone in under anesthesia. First, group A, we never say them stage. There is nothing word like I usually see stage A, stage B. These are all the groups. Because why we say group? Because one group has many manifestations and it represents with many signs. We cannot write every sign in the classification. Okay. Group A, small tumor, 3 millimeter, less than 3 millimeter outside the macula. Very easy. Group A tumor is very easy, but it's how common it is. How many of us see the group A tumor? Hardly. In one eye, it's a group D, then you see the other eye, group A. Otherwise, none of the presentation, even in the Western world, in the advanced world, you hardly get a tumor of group A in your clinical practice. So it's the easiest one that you can pick. God has made the disease, the start is very easy, the end is very easy. Middle between is very confused. Believe me, it's very confusing. Whatever it is, the situation. It's very easy. You find a white boil-like thing or disc-like thing in the retina somewhere. It's a group A, very easy, very well done, no problem. Group B. Group B, tumor is more than disc, twice the disc, but you are confused whether it's A or B. I am talking about the clinical thing. I am not portraying this classification. This is everywhere. You can just do a click of Google and you will find it on your mobile. This classification has nothing to do with the clinical understanding of the disease. It's very important for you. Tumor more than 3 millimeter. Okay, how you understand more than 3 millimeter? A tumor that is not of the size of the disc. It's for general concept. Not of the size of optic disc bit, the optic disc. You should go for B. It's still easy. The situation is still easy. And subretinal fluid. Believe me, the subretinal fluid, if you are not doing under the anesthesia examination, you cannot find this subretinal fluid. It's very difficult. It's very difficult without indentation even. So with indentation, it's sometimes possible. Situation critical starts from C. How many of us sees the vitreous seeds or subretinal seeds? How many?
One in very rare, very rare. And do you think it's very easy to find the seeds? It's very difficult, even in the vitreous cavity. And these are not common as they are classified. They are very rare. Subretinal seeds, oh my God, believe me, it takes few minutes for me to indent the retina and see whether they are over there or not. I am basically retinal surgeon. For me, seeing the retina is more than seeing the cataract in daily life. So it's even for me very difficult. For even experienced ocular oncologist, it's very difficult to see the subretinal seeds. Believe me, it's very easy to write it here. See subretinal seeds, very good. Who will find it? Who will identify it? And how many types we know about the seeds? Do we know whether it's a seeds or whether it's exudation? So it's very important. I will go further for this one. So whenever, to simplify for all the residents and fellows, whenever you find any seed in the vitreous or subretinal space, in the vitreous it's very easy. You can easily find around the tumor. Tumor is size B, around the 2 disc or around the 2 disc, but you find a single seed. Seeds are always lying down, believe me. They are most of the time they are lying down because of the gravity. Seeds are the balls, they are different shapes. So whenever you find a seed, wherever it is, label it as a C. Keep it for C for seeds. C for seed. So whenever you find a seed, it's a group C. Never label it B, never label it D. What I see, someone say label it B, someone label it D. But they are confused. Just when you are not sure it's a B, try to find a seed. If you find even a single seed in the vitreous cavity, that's very easy. Subretinal is difficult. Then it's a C. Whatever the size is going on. Don't think about the size at that time. Now come we about the group D. I say it's a localized seed. Professor Sardar Ali says it's a diffuse seed. How we will come to the consensus? For me, it's a localized. For Ali, it's a diffuse. Where is the parameter? Anybody can tell me the parameter of diffuse and focal? Where it is written that this cavity of vitreous, if is filled, it's a diffuse. If this cavity is filled, it's a focal. Did you read anywhere in the world about it? But they put it in the classification. Then how me and Ali will come to the consensus whether a diffuse or focal? Nowhere. So you see, this classification tells everything, but it tells nothing about the clinical science. You see, very, very easy for anyone. Diffuse seeds, group D, very good, clear. No, how you will differentiate? No way. So this is what your clinics will tell you. Group D, any tumor that has a size of group C. Group C, little bit bigger than 3 millimeter, but few seeds. When you find massive seeds and globe is filled around the 50%. So here comes the difficulty. I say 50%, Professor Intadar say it's not, it's just a 30%. Where it stands 50%? That we can conclude by the radiologist, by ultrasonography. That's where we can get the help. But the issue is that when it is endophytic, then who is going to measure the size? When it's exophytic, who is going to measure the size? It's difficult. Subretinal, to see the size, whether it's a diffuse or whether it's not, it's far more difficult. It's very easy when the tumor is lying over the retina. You can see the size, you can see the seed. When tumor is lying under the retina and giving a bullous exudative retinal detachment, then can anybody see the size of the tumor at that situation when you have exudative detachment and tumor is lying under it? Does any? So then how you can classify? How Taiba, anyone you will, Aisha will classify? There's an exudative detachment. You don't know the tumor size. So how you will classify it? It's a C, B, whatever it is. No? It's difficult situation again. Here, and when you are doing for group D, first, seeds should be there, whatever the exudation it is. Exudation is there, it's okay. Detachment is there, okay. When it's over the retina, it's easy. Any tumor filling the cavity around 50%, you are see how you identify it's 50%. A 20 diopter lens, indirect ophthalmoscope on the head, whatever you see with the 20 diopter, if no retina is visible, it's almost more than 30%. Very simple trick. Pupil dilated, put the 20 diopter lens, you see, no retina is visible, just a tumor is visible. More than 30%. So you are already around the group D. So any tumor that is filling your field on the indirect ophthalmoscopy and present with the seeds is group D. Now it's clear. It's still confusing. Now, how you will assess whether it's a progressive disease, whether it's a stable or it's a regressive? This is where the main catch is. You know, retinoblastoma starts progression by itself. With the passage of the time, I've seen many retinoblastoma, calcified, fully regressive, never been treated. So if you find a group D, how you will know it's a progressive disease, it's a stable one, or it's a regressed one? When we talk about the calcification, it's not always calcification. I mean, we have labeled the retinoblastoma with the calcification. For God's sake, nothing has to do with the calcification nowadays. Whenever the calcification, it's a retinoblastoma. When we talk about the regression, it's a calcification. Same word for everything. Nothing to do with the calcification. You should know the cardinal signs of progression of the disease and cardinal signs of regression of the disease. If you don't know those signs and you haven't seen those signs for millions times, hundreds times, you wouldn't find those signs. Don't rely. MRI, B scan, these are topographical measurements. These doesn't tell you the progression or regression of the disease, believe me. This is just showing the anatomy. We are not dealing with the cadavers. We are dealing with the live human tumor. So, okay. D. So if I will have a time, I will tell you the few signs that you should know by heart, because a tumor that has been treated by me and my colleagues, fully regressed, everything gone, been enucleated somewhere else. Because it's a retinoblastoma, there is a calcification. For God's sake, it is calcification. So you should know the cardinal signs of regression of the disease. Nothing has to do with this classification. This classification tells you 6 lines only. Every resident knows before passing the fellowship exam. But you should know the iceberg behind this classification. There's a big story behind this classification. You should know. Now come to the E. E, very simple. I told you group A and E are very, beginning is very simple. So there is a one hero and heroine, and ending is very simple. They got married. Okay. So this is just an icebreaker. Don't mind it. So group E. Group E is very simple. Whenever you see an eye, he will be in pain. He or she will be in pain. Whenever you see ectropion UV and NVI and he or she has, how you diagnose? First day I am doing the IUA, MR is not available, B scan is not available. Very easy. Ali examine the eye, Ali says, oh my God, NVG, it's like ROP or course, whatever, don't know. Very simple, examine the other eye. That will have a B or C or D, very easily. If that is retinoblastoma, so most probably this one is also there. So if you find NVI or vitreous hemorrhage in an eye that is suspected for retinoblastoma, because you wouldn't be able to see beyond it. Usually they have a cloudy cornea and poorly dilating pupil. So look for the other eye. Other eye has the retinoblastoma. Then you can label it preliminary as a group E, confirm it with the B scan and MR report. Okay. So it's there. Group E is easy. Group A is easy. But something between all these is a bit difficult. I will be quick. around the group A. So here you can see the group A. Optic disc, little bit more. It's very easy. No issue at all. Anything white lying over the retina like a boil. Why I'm saying boil? It looks like a boil. So is there. Group B. That is not around the disc or little bit larger. See, this is the disc. You multiply it by 3. Very easy. Okay, here. So it's a group B. Subretinal fluid. Here it is. But it's very difficult. If we will dim little bit lights, then you can see. But I just put this slide to show subretinal fluid. But it is difficult. But it is sometimes very difficult. Now come to the group C. Here you should need to find these ones. Okay? You got my point? Find these ones. Whenever there is a seed, it's a C, minimum C. It's not a C, it's minimum C. Treat it like a C minimum and then think about the D. We differentiate retinoblastoma with the course when we are resident and fellows. We differentiate retinoblastoma with retinoblastoma when we are consultants. So here is the main point. So group C, when there are seeds. Okay, this is clear for everyone. Now we go to the group D. What I told you, anything that is filling almost the size of half of the globe, okay, and with the vitreous seeds is named as D. Acha, what's the difference between D and E? I told you that picture of group D will be similar to E, but you should get NVI, vitreous hemorrhage. So to label it E. So keep it in mind. NVI, ectropion uvea, and vitreous hemorrhage. If it is there, all the other things that we talk about, the classifications are just mimics that you will get thysical eye. Thysical eye you can get in any stage. If even it is treated, you may get in thysical in group C. So don't talk about those things that are just a textbook thing. So once again, retinoblastoma has never read the Kansky. Okay, just keep it in mind. So as I should continue. Okay. So as we talk about the group D, so D should be somewhere like E, without NVI, without vitreous hemorrhage. Then you can label it group D. Don't think whether it's a filling half or whether filling more than half. I told you the trick. With the indirect ophthalmoscopy, you can easily identify whether it's filling how much vitreous cavity is. The issue starts over here when we get the group D. Sometimes when you have an exudative retinal detachment and you cannot identify the tumor size under the retina, there is no way. Whatever the experience you have, you cannot see the tumor behind the retina. It may be where the situation gets confusing. You get enucleated that eye, and at enucleation, histopathologist tells you that the tumor size was this size. And you say, oh my God, this could have been treated very easily. Does it happen? It happens. So exudative retinal detachment has nothing to do with the group. Be with me. I know everyone knows this classification, but you have to understand this one. So it's not always a group D. So how you will identify the size of tumor? That's very important here. So first thing is you can do the B scan. Sometimes B scan doesn't tell the full story. So what you should do? MRI is the right choice at that time, but not with the sedation, with general anesthesia only. That will tell you the exact size of the tumor and extents of retinal detachment. And sometimes what happens? It's not always that you get a bilateral retinoblastoma. You may have a retinoblastoma in one eye, other eye may represent another disease. So you should be sure before going for any further management step. So I think I have tried to convey how to differentiate it, and what are the cardinal signs that is not written in the book, but the disease speaks about those signs. That's a very important. Now we go the group E. Group E, NVI or vitreous hemorrhage and retinoblastoma is usually seen behind the lens. Whenever the retinoblastoma is touching the anterior hyaloid, it is always almost NV group E. There will be NVI, there could be NVI, but you have to make sure. Now we go further. So this is the main thing. We are talking about seeds. How many of us know about the seeds? How they represent the seed? And what are the types of the seed? And it's very difficult, believe me. Looking at this, one of my fellow label it as a retinoblastoma. You see how similar this one is? Anyone of us may have labeled this one. Looking at this, somebody has said that these are the tumors. Okay? So first, you should know the signs of progression or regression of the disease. You should know the seeds type. This is the dust type seeds. Mostly in our part of the world, 70% gets these types of the fair one. Do you agree? In our most of the patients, the in vitreous you see these fair ones. These clouds ones are there, but they usually present in the patient who has the other eye, a group D or E, and you see such like picture in other eye where it is developing. So it's a group, it's a clouds. Clouds are sometimes difficult from the actual tumor. So don't label this as a regressing tumor, please, for the God's sake. These are not the regressing tumors. These are the seedings of the retinoblastoma. I think if I will have a time, I can talk. Do I have a time or my time is 5 minutes? Oh, that's good enough. So be with me. We have talked about the group A, B, C, D, and E. Okay. Now, anyone from the hall can easily label where it's a group D. It's very easy. But think yourself in the real scenario, a kid is lying and you are doing the indirect ophthalmoscopy. Do you think it will be easy? Still easy? No. How it becomes very easy? Anyone? You should think whether seeds are there. First, this is retinoblastoma. Nobody cannot deny because my eyes know this is retinoblastoma. Okay? This is confirmed. First, I will look for seeds. It is a bigger size, can't be seen because my full indirect ophthalmoscopy view is covering the view. So it should be D. Should I confirm? Indent the eye, tilt to the temporal side. Still the tumor is there. Confirmed. It is more than 30% of the globe. So always, always do the examination under anesthesia with indentation. This is clear for everyone. There is no excuse, believe me, there is no excuse that I cannot examine under anesthesia. I can postpone my patient for 2 days, for 1 week, but I will never do an examination of retinoblastoma without anesthesia. Never in my life. Never ever. Even they will beg, I am from DG Khan. I am from Balochistan. Please do it today. No, no way. I'm not going to treat you as an animal. So keep it in mind. Examination under anesthesia, few puffs of sevoflurane. You have done your job in 2 minutes with the ethics. Do the indentation always to size. Now, sometimes what happens that you find such pictures and a tumor is lying. Don't confuse about it. Seed, what I tell you the trick. Be with me, please. What's the trick about the seeds? Anybody can tell me? Seeds never has the vessels. Seeds never have the vessel. Tumor always have the vessel. Now you are clear? Seeds will never have the vessel. When seed will have the vessel, it is a tumor already. Clear? Things are getting clear a little bit? Okay. So now you know how to differentiate between seeds and actual tumor. 2 minutes. Yes. So what next? I will tell you only 2 words. Just keep these 2 words in mind, please. This is I am talking about everyone who is treating the retinoblastoma or examining the retinoblastoma should know the signs of progression or regression of the disease. For God's sake, nothing has to do with group A, B, C, D, E. If you don't know the sign, आपको ये पता ही नहीं है कि दवाई का इलाज करने से बुखार कम होने की अलामत क्या है, तो उस इलाज करने का क्या फायदा है? Is there a logic to get a pill of fever and you don't know what are the signs of having the fever? You labeled it group D, you started treating, but you are examining every time and you are saying, I don't know whether tumor is progressing, disease is regressing the disease, or tumor is progressing with the treatment. So now we come to the point that then the most important thing is classification is important only to decide the treatment plan. But treatment plan is already written in the book, and retinoblastoma knows that book. What has been written for it? Okay. So the main thing is that you should know whether this treatment that has been planned by an ocular oncologist or radiologist, whatever, whether it's a working. He or she not going to tell you. No. Even the radiologist cannot tell you whether disease is regressing. When he will tell you the disease is regressing, it's a size regression. Size regression never tells you that disease is regressing. And size regression comes when disease has died down. It will be very late if it is a progressing. So 1 minute, 2 signs. Okay. When you see vacuolation, what you see, vacuole in the tumor, empty spaces in the tumor, this is the first signs of regression. Forget this calcification, for God's sake. Okay, vacuole. And when you see that the vascular component over the tumor is decreasing, you should measure the vascular component. If you are a good physician, you should measure the vascular component. That drawing should show that how many vessels were there, or your imagination should remember it, that how many vessels were there. After 2 cycles, where are the vessels? No vessels. Few calcific spots, 3 vacuole. Good response of chemotherapy is going, hit it more. So 2 things, vacuolation and regression of the vessels. These are the cardinal signs that tell you the disease is regression. Don't put this burden on the radiologist. Right, sir, tell me whether it's a regressing or not. How he can tell you? He is just seeing the anatomy. How he can tell you? He will tell you tumor was 5 millimeter, now it's a 6 millimeter or 4 millimeter. When it will be 4 or 6 millimeter, everything is gone away. It's too late. So I think next thing you should know about the treatment plan. Somebody else will. Most important thing is grouping of the disease and knowing the cardinal signs. I tried my best just to convey the things that are utter important for the clinician. Once again, we have read the retinoblastoma in the book. Retinoblastoma has never read our ophthalmology book. So keep these things in mind. Have a good day. I think we will keep in touch. We are working for this disease from so many years. We have a promotional videos, we have a TV interviews, so much doing, but we need a big team in Pakistan to treat this disease. This is not very important disease for ophthalmologists because there is no bread and butter and nobody likes this disease because there's a lot of neck pain for me. From last 15 years, every year I'm doing more than 2,000 EUA on indirect ophthalmoscopy. There's a lot of neck spine and every kid is crying. Every mom is asking when you will save this side, whether my kid will die, whether his eye will be inoculated. You said disease has regressed. Now you are saying disease are recurred away. So I am answering these questions from last 16 years. I am still ready. I need more people to answer these questions with me. And we have to fight this disease. This disease has a much more prevalence as it's written in Western book. So join our hands. We have to fight this one because sometimes we should think that we are going to the next world where this cataract or all these surgeries are not going to save us. Thank you so much.
Ladies and gentlemen, I feel great pleasure in announcing that we have been joined today by a very scintillating conglomeration. We have with us our respected Vice Chancellor, King Edward Medical University, Professor Dr. Mahmood Ayaz. We have been joined by our worthy Chief Executive Officer, Mayo Hospital, Lahore, Professor Harun Ahmed. We have our Medical Superintendent, Dr. Munir. We have our Dean Surgery and Allied, Professor Dr. Naki. I request all the worthy dignitaries to please join us on stage. I request Professor Mahmood Ayaz Saab to please come on stage. I request Professor Harun Hamid to please come on stage along with him, Professor Naki, Dr. Munir. They will be joined by Professor Emeritus, Professor Asad Islam Khan, and our chairperson, Professor Muhammad Moin.
Assalamu alaikum. Thank the worthy guests for gracing the occasion. Just a brief outline of what we are doing today. Oh, Professor Abrar Ashraf, please do come abroad. Do come up. He's Director of Medical Education at King Edward Medical University. Since I've come here to Mayo Hospital since March. So my main aim is to promote academics. So one of the main thing which we are sort of planning to do, or which we are incorporating in our daily routine activities, getting more of these conferences. And you can see we have this thing live on Zoom as well. And we've got an audience of 20 to 30 people on this. And we are recording on the session, and we are going to distribute or upload on YouTube as well for people to see at a later stage. What is retinoblastoma? Well, it is the most common childhood tumor which is present in children. It is in our region. India has got the highest incidence in the world. I think Pakistan is near that region, so it comes into that area. When Professor Munirul Haq started, probably at that time, retinoblastoma, all the surgeries were done, enucleation, exenteration. Now, with the help of our pediatric colleagues, we've got chemotherapy, which is very highly effective, and we can reduce the amount of enucleation and exenterations to very minimal treatments. And with the help of our radiology colleagues, we can diagnose it much earlier and see what type of spread it is doing. And today, what we want to do is to build a platform which we have got people from different hospitals in Lahore, which include Children's Hospital, Lahore General Hospital, Shaukat Khanum, and from Al Shifa Trust in Rawalpindi. So we've got a group of people who are all interested in doing retinoblastoma. We have sort of had initial presentations, and the next step is to have a group discussion on how we can collaborate together, make it a sort of a better disease to treat, and to make the children of Pakistan sort of safe from retinoblastoma, or to prevent it. Because I showed my story initially, I think Dr. Zimmerman, he was in New York, and his child, Larry, he got retinoblastoma, and he was interested to save him. And at that time, he said that we can give him intracarotid chemotherapy, but that failed. But then external beam radiotherapy was used at that time. And that point, that thing started off, and that the Rees-Elworth classification started off from that time, because those were the physicians who were treating his son. Then the son, Larry, he was a banker, and then he had children, and one of the children, Perry, she got retinoblastoma, and she was saved because of early treatment, because they knew it was retinoblastoma. And then the second child, they had genetic testing, intrauterine stage, and they could test that there was retinoblastoma and could treat it earlier. So over time, the treatments have evolved. Now we've got the most advanced treatment, which is intra-arterial chemotherapy for retinoblastoma. We were proud that we were doing it at Lahore General Hospital, and Dr. Lubna, Professor Khakan, they're both actively involved.
And Professor Shahid is here. Thank you very much for coming. He's, I think, the lead at LGH for pediatric cancers over there. Thank you very much, everyone, for coming. And now I'd like to ask Dr. Sidra to continue the.
2 minutes. So, Assalamu alaikum. I am Dr. Mohammad Salman Hamza. I am a senior star Unit 2, and I am also the joint secretary of Pakistan Oculoplasty Association. So, my topic is enucleation and post-enucleation syndrome. Zahir, run कैसे हो रहा? इस पर नहीं हो रहा. So, before going to enucleation, one should understand what is post-enucleation syndrome. अच्छा ये असद साहब ने मुख्तलिफ प्रेजेंटेशन तो दिखाई थी रेटिनोब्लास्टोमा की, लेकिन एज ए ऑक्टोप्लास्टी सर्जन व्हाट we face like this child. The survival child is also a problem. Retinoblastoma is not the thing कि जो एक दफा entertain हो जाए, इसको पोस्ट ऑपरेटिव रिहेबिलिटेशन की भी जरूरत होती है. सबसे कॉमन जो हम प्रेजेंटेशन फील करते हैं, जो एज ऑक्टोप्लास्टी सर्जन करते हैं द सर्वाइविंग चाइल्ड में, वो है पोस्ट इन्यूक्लेशन सॉकेट सिंड्रोम, व्हिच इज कैरेक्टराइज्ड बाय एनॉफ्थल्मोस, सुपीरियर sulcus deepening, upper lid ptosis, lower lid laxity, shortening of the fornix and the lag of ophthalmos. Or another abnormality is the facial asymmetry. Remember one thing, that orbits grows with the reference of the orbital tissues. If orbital contents are not there, orbital growth will stop. And the bony orbit will remain at the same size. So the bony orbit, the bone gets fused, and the size of the whole face becomes shortened. When all the orbital bone fuses, it not only causes the smaller orbit, but it causes the whole of the facial asymmetry, which is characterized by the deep orbit and also underdeveloped maxilla, underdeveloped zygoma, and the nose is drifted at one side. Jaw is also tilted. You can say that the patient had two faces. बिल्कुल एक दूसरे से अलग अलग faces होते हैं. It's really difficult to rehabilitate that sort of patients. So the problem that the patient has to face is not only the cosmetic but also the social and the psychological and the economical dilemma of the society. अभी मैडम बता रहे थे कि बच्चा स्कूल भी नहीं जाता, ये इतना बड़ा डिलेमा है कि कॉस्मेटिक इशू की वजह से सोशल इंटरफेरेंस भी कम हो जाती है. So to reduce that effects, we need a very good enucleation, and enucleation with something with implants. We have to replace the eyeball with something कि उसमें बिल्कुल empty socket नहीं छोड़ना हमने. So enucleation is not only the removal of the eyeball, but it's also the removal of the optic nerve attached to it. It's necessary. खाली eyeball ही target नहीं है. Target is the optic nerve also. So goal of the enucleation is to prevent. This is the main target. To prevent the intraocular tumor to become extraocular. अगर एक अच्छा enucleation हो जाता है तो tumor उधर ही खत्म हो जाएगा. सारे sequelae block हो जाएंगे. This is the goal of the enucleation, and it wouldn't be happen without a very good enucleation with a very good length of optic nerve. Other goals are to maintain a very good orbital volume and to maintain the good fornix depth. These are some indications which might be primary and the secondary indications. Time, right decision, right time पर enucleation करना बहुत जरूरी है. अभी जिस डॉक्टर खकान कह रहे थे ये confusion होता है कि ग्रुप डी है, ग्रुप ई है, ग्रुप सी है, और उसके अंदर बहुत प्रीशियस टाइम जाया हो जाता है. तो राइटली टाइम पर डिसीजन करना enucleation का इज नेसेसरी. These are pre-operative measures जो कि आप लोगों ने लाजमी चेक करना है before going to the enucleation. Identify and mark the eye. Always do a fundus examination before going enucleation. Take informed, check the informed consent. कई दफा आप ये सर्जन की जिम्मेदारी है to check the informed consent. And two consultant approval will be helpful in legal proceedings and should be done by the experienced surgeon. ये भी एक myth है कि अक्सर enucleation assigned to the some junior people, but I think so it should be the experienced one क्योंकि बच्चे की जिंदगी इस वक्त उसके हाथ में है. It's a survival rate सारा एक सर्जन के हाथ में है. जितनी अच्छी enucleation करेंगे उतना अच्छा रिजल्ट हासिल करेंगे. Always check the CT scan and MRI before going for the examination on enucleation. Check the enucleation seizure बहुत important है, and arrange the blood for the transfusion. So enucleation start with the 360-degree peritomy and it should be close to the limbus. Try to save every millimeter of the conjunctiva. Two relaxant incisions should be given at supratemporal and infratemporal quadrant and to get access to the subtenon space. And after that, a blunt dissection should be carried out to get access to the extraocular muscles. Lateral conthottomy again a very important step जो कि अक्सर लोग नहीं भी करते हैं, लेकिन lateral conthottomy अगर स्टेज पर हो जाए तो आपकी अप्रोच इजी हो जाती है. दिस इज द न्यू स्टेप जो कि इमरान साहब ने इंट्रोड्यूस किया था इसके अंदर के अपने आप को इजी करें. लेटरल कंथॉटमी इज नेसेसरी. जब आप पेरिटोमी कर लें उसके बाद लेटरल कंथॉटमी कर लें. Then engage the whole muscle. Leave 2 to 3 millimeter of the muscle stump. That will be helpful in lifting the globe from the orbit. So for that, apply 60 or 40 vical suture 4 millimeter away from the muscle insertion, and then cut the obliques. After that, cutting the and skewer the rectal muscle, cut the obliques muscle, and skewer the hematosis at every stage. These are some points to get the longer length of the optic nerve. Number one, you should move the glove forward, free the optic nerve from the connective tissue. Nasal approach and both temporal approach can be used, whichever is convenient to you. And target to get 15 to 20 millimeter at least optic nerve content. For that, you should dissect and try to reach at the orbital fissure level. Or 2 to 3 millimeter इसके बाद आपने cut down कर देनी है. So you can have a very good optic nerve. So in the survival, every millimeter of the optic nerve matters. After that, inspect the globe carefully for any scleral thinning, perforation, dilated vessels, extraocular tumor extension, and अगर कोई ऐसी चीज मिलती है, mark it. Histopathology में ये जरूर mark करें. Hemostasis of the optic nerve it will not be a big problem. Just it will be hemostasis can be achieved with only 5 to 10 minutes firm pressure. Again, now the cautery can be used. So it's not necessary to ligate the nerve. And never ever apply artery force over the nerve. No, don't crush the nerve. And then after that, place appropriate size implants. Different types of implants can be used. It may be integrated, semi-integrated, non-integrated, or the bio implants can be used. Most commonly used is the Allen's fenestrated semi-circular, semi-spherical, semi-integrated implants. It do have fenestration in it through which the rectal muscle came, and by this you can hold the implant properly. अगर एक मसल रह गया तो ये इम्प्लांट नहीं काम करेगा. इस इम्प्लांट के लिए चारों मसल, चारों रेक्टाई का होना बहुत जरूरी है. आफ्टर पासिंग थ्रू ये चारों मसल इसमें इंगेज कर लेते हैं. Innovation came from the Professor Imran Sahab. He has he has made this implant whole sphere. पहले Allen जो है वो hemispherical है, इसको उन्होंने पूरा sphere बना दिया. This is the anterior part और ये इसके ऊपर आके attach हो जाता है. इसके एडवांटेज ये हैं कि कटिंग एज ऑफ द जो कटिंग एजेस होते हैं वो उसके मैनेज हो जाते हैं. और it can be implant size can be adjusted and easy to replace. It's cost effective and readily available. दूसरा इम्प्लांट जो जिसमें मसल या ऑर्बिटल टिश्यूज कम है उसके लिए सॉफ्ट ऑर्बिटल इम्प्लांट है. इट्स अ pear shape implant and that has this unique structure that reduces the spherous sulcus depression. This is the way it has been implanted. After then, close the tenon and the conjunctiva in the layers. Look at that. Complication can happen at any time. Three muscles are there, one muscle is missing because when moving or cutting the optic nerve, we can have the valve muscle. So this implant, half pear shaped implant, is very useful in getting the orbital volume in that cases. And if you have seen extruded implant due to chemo radiotherapy, you can manage it with the dermostat graft very easily. Other complications are these effect. Radiotherapy can also affect your outcomes. Contracture of the anophthalmic socket and radiation also causes the radiation dermatitis. Orbital bone को deform कर सकता है, और it also causes the bony atrophy or cartilage, and finally the fat necrosis. Fat necrosis के लिए हमें dermis fat graft उसमें डालना पड़ता है. Thank you very much. Thank you, sir. Sir, you are not supposed to crush it. अगर let's say कि किसी भी तरह से ट्यूमर के कुछ सेल्स उसके अंदर अप्रोच हैं, it was sediment. जैसे आपने क्रश किया, क्रश एंड के साथ वो सेडिमेंट कर देते हैं. हाँ हाँ. अच्छा, इसमें एक चीज है कि जो मैश है या इंटीग्रेटेड इम्प्लांट या पोरस इम्प्लांट्स वैसे बहुत अच्छे हैं, मतलब इसमें कोई शक की बात नहीं है. लेकिन अगर ये इन्फेक्ट हो जाए या कुछ और हो जाए तो इनसे बुरे इम्प्लांट कोई नहीं. इसके अंदर ग्रेनुलेशन टिश्यू ग्रो कर जाता है, और अगर एक दफा भी इन्फेक्शन हो गई, इन्फेक्शन कभी आप खत्म नहीं कर सकते. वो अंदर इम्प्लांट और मैश के अंदर फैलता रहता है. नहीं, वो पता लग जाता है, उज़ आ रहा है, स्मेल आ रही होती है, यू कैन सी. मतलब हाँ, मतलब आपको हर वक्त डिस्चार्ज, पेशेंट आता है डिस्चार्ज के साथ, और इतनी मतलब जब पेशेंट आता है ना, कई दफा स्मेल अंदर से आ रही होती है और बहुत मुश्किल से रिमूव होते हैं, बहुत ही मुश्किल से रिमूव होते हैं. तो काइंडली अवॉइड. या तो अगर मूवमेंट के हिसाब से देखा जाए तो इससे अच्छा इम्प्लांट है, लेकिन एक दफा इन्फेक्ट हो जाए. हमारे यहाँ देखें जिस तरह पोस्ट ऑपरेटिव केयर बहुत अच्छी नहीं है. पेशेंट मतलब पट्टी की है तो 3 दिन पट्टी रखेंगे, कोई ड्रॉप नहीं डालेंगे, तो इसकी वजह से इन्फेक्शन बहुत ज्यादा कॉमन है. जी सर, मतलब नहीं, इसके बहुत काम है. इसकी डिजाइन इस तरह का है, इसकी जो शेप है ये पियर शेप है, और ये एपेक्स के साथ और फ्लोर के साथ एडजस्टेंट हो जाता है. इस
पेयर बनाने का क्या मकसद है उसको?
सर, इसकी जो ऑर्बिटल कैविटी के साथ ही डिजाइन की है, जिस तरह ऑर्बिटल एपेक्स की तरह, उसी तरह वो इम्प्लांट पूरा शिफ्ट हो जाता है. इसलिए एक जगह पर उसकी कोई फोर्स नहीं लगती, जो फ्रंट पर फोर्स नहीं आती.
मूवमेंट नहीं है उसमें?
मूवमेंट नहीं है सर.
मूवमेंट
इट्स वेरी गुड फॉर ऑर्बिटल वॉल्यूम रिप्लेसमेंट.
एक्सेंट्रेशन वगैरह के लिए नहीं कर रहे हो सबसे ज्यादा?
सर, जिसमें मसल फैट एट्रोफी होगी उसमें भी बहुत डल जाता है सर. जिसमें मसल्स वगैरह नहीं है उसमें भी डल जाता है सर.
हाफ इम्प्लांट में उसके एक्सट्रूजन के बहुत ज्यादा केसेस आते हैं उसमें, उसकी क्या वजह है?
सर, उसकी वजह जो इंटीरियर पार्ट है उसकी वजह मेनली रेडियोथेरेपी, कीमोथेरेपी, या अप्रोप्रिएट साइज को नहीं डालना.
तो दूसरा आम भी डाले तो उसमें भी एक्सट्रूजन के आती थी
सर, जो ऑर्बिटल है उसमें तो बहुत कम एक्सट्रूजन है. जो हमने देखी है ना, वो जो इंटीरियर पार्ट वाली है उसके अंदर एक्सट्रूजन हो जाती है सर.
मैं तो यूएस में भी जिसको फेलोशिप कर रहा था तब भी वो स्फेरिकल इम्प्लांट सिलिकॉन का वही डाल रहे होते थे. मूवमेंट तो आ ही जाती है उसके साथ, वैसे भी आ जाती है उसके साथ, लेकिन मेरा मतलब ज्यादा तो उसमें इसहाफ इस्तेमाल किए हैं, लेकिन उनका सबसे बड़ा इशू यही आता है कि उसकी एक्सट्रूजन का मसला आता है उसमें.
सर, हमारा तो अच्छा एक्सपीरियंस बल्कि जो एक्सट्रूडेड इम्प्लांट्स की ये अच्छी रिप्लेसमेंट है ये.
Deep into the orbit, the implant, it needs to be placed inside that bone. और आपका टीनॉन अगर उसके पीछे आप बहुत ज्यादा छोड़ देते हैं और उसकी इंटीरियरली कवर इज नॉट गुड और आपका क्लोजर अच्छा नहीं है, तो बहुत अर्ली एक्सट्रूजन होती है.
Definitely, it also,
Implant also, surgical technique also matters.
बिल्कुल बिल्कुल इसीलिए मैंने आपको पहली चीज कहा कि जी एक्सपीरियंस सर्जन चाहिए इसके लिए, ये नॉट सिंपल चीज नहीं है, वन शुड बी वेरी एक्सपीरियंस।
एक इम्पोर्टेंट चीज है कैक्टस सिंड्रोम कहते हैं, वो मतलब जेफरी रोज उनसे या उनके पास गए थे तो वो कैक्टस सिंड्रोम कहते हैं। कहते हैं जिसको बॉल डाल के रखे, आप जिसको तक डालने देखे फौरन बाहर निकल आते हैं। अगर वो निकलता है तो इसके लिए दूसरी तकनीक ये थी, ग्लव के फिंगर को काटे, बॉल उसके अंदर डाले और वो जो इसका फिंगर का पार्ट है ना, अपनी मेन किसके फिंगर उसके पीछे ले लीजिए, तो बॉल को आप जो आपका सॉफ्ट टिश्यू उसके पीछे डिलीवर करने जा रहे हैं, तो फिर वो सॉफ्ट टिश्यू से बाहर नहीं निकलेगी। ड्रैग जो है वो कहते हैं जैसे गिर जाता है तो वो बाहर निकल जाता है। जब आप जब ड्रैग करते हैं टिश्यू को, जब अंदर से डालते हैं बॉल, तो वो बॉल ही ड्रैग करके टिश्यू को लेके जाता है, वही बाहर आ जाता है। तो ये नीड तो जिसका फोल्डर एग्जाम्पल डालते हैं उसमें इंजेक्ट करके बॉल को पीछे ले गए अंदर निकल के फिर बाहर नहीं आए।
हाँ, इंसर्टर नहीं है हमारे पास।
लेकिन इससे फिर भी इसका भी सॉफ्ट टिश्यू चला जाता है। ये तो
अच्छा सर, इसमें एक
लेकिन इसमें ये है कि वो उससे डालने की डिलीवरी किससे होता है, वो खुद ही किससे जा रहा है, वो बोलते हैं कर रहे थे, तो दैट इज व्हाई वो पेपर भी पब्लिश हुआ उनका कैक्टस सिंड्रोम के नाम।
हम
पर
लोग
क्योंकि वो मेडपोर वगैरह इतने आगे जा चुके हैं तो वो इतना पब्लिसाइज नहीं होता।
हम लोग जो कर रहे हैं वो ये कि हमारे पास वो इम्प्लांट इंसर्टर तो नहीं है, लेकिन हम एक्सरे लेते हैं पेशेंट का, जो हमारे पास जाहिर शुदा एक्सरे हैं उनको हम ऑटोक्लेव करवाते हैं, वो हो जाते हैं, उनका हम वो कोन बनाते हैं और वो उसको हम एज इंसर्टर यूज करते हैं, उसके अंदर से भी हम बॉल पीछे करते हैं। हाँ जी, एंड एप्लीकेटिंग दैट, और जुगाड़ करते हैं ना, पाकिस्तानी है ना हम, तो वो हमारा फ्री ऑफ कॉस्ट या वो हो जाता है। तो अब ये इसके ऊपर हम जो है इंशाल्लाह ताला स्टडी भी करेंगे कि कितना इफेक्टिव है, ताकि हम यहाँ पे जुगाड़ कर सकें, क्योंकि हर सेंटर में इंसर्टर का अरेंज करना मुश्किल है। लेकिन ये अभी तक जो है फॉर द लास्ट 4 years हम लोग यही कर रहे हैं। आप थैंक यू।
जी मैडम।
pediatric oncologist at Shaukat Khanum. So I don't know all the surgical techniques, but what I do know is कि हमें जो periphery से patients refer होके आते हैं, उनके implants नहीं डले हुए होते हैं. So is it possible to place the implants when they come to us? Like, can we send them to surgery again?
But implant can be placed at any time.
At any time.
At any time. और जितने जल्दी हो सके डाल दें, वरना फेशियल एक्सट्रीमिटी बहुत बुरी बन जाती है, बहुत बुरी बन जाती है। एक दफा बोन क्लोजर शुरू हो गया, you cannot stop it. तो ऑर्बिटल वॉल्यूम को मेक श्योर कि ऑर्बिटल वॉल्यूम अच्छा बन जाए, उसके अंदर कुछ ना कुछ हो, क्योंकि बोन ही ग्रोथ जो है डिपेंड्स द ऑर्बिटल कंटेंट्स। अगर एक आईबॉल नहीं होएगा, ऑर्बिटल वॉल्यूम कम होगा, तो बोन उधर ग्रोथ रुक जाएगी। we can change.
So how frequently you keep on changing the implant?
Keep on changing. Keep on, yes.
How frequently? I mean, should we, for example, patients are coming to us after retinoblastoma, patients are coming to us for follow-up. So how frequently we should expect you will change the implant?
Whenever you feel that conjunctiva या lose हो गया, fornices lose हो गया, फौरन replace करते हैं इसमें. When you have space, replace it.
And one little question, do we have some assistance locally available to donate these implants, some donations for these implants?
Easily available है.
The prosthesis कुछ दो parts में आएगा, पीछे implant डलेगी, फिर आगे
Prosthesis से क्या price है जो?
वो तो ये बनाने वाले, वैसे अगर इंडिया से बने बनाए जो आते हैं वो तो 5-6 हजार या 8-10 हजार की मिल जाते हैं, लेकिन ये जो बनाने वाले हैं या वो कोई 20 का भी बनाता है, 50 वो लाख से ऊपर भी ले जाते हैं।
So उसके लिए भी हमने कुछ
वो तो उसी से
नॉर्मल क्वालिटी ऑफ लाइफ बहुत बेहतर हो जाती है।
वो तो
सर, बड़ा एक
obvious
जनरल
बात।
क्वेश्चन होता है, इनिक्लेशन की जब हम काउंसलिंग कर रहे होते हैं, रियली हेल्प अस अ लॉट कि हम एक उनको बच्चा दिखा दें कि दिस बच्चा अंडरवेंट इनिक्लेशन एंड नाउ कैन यू एक्चुअली डिफरेंशिएट कि इस आई की सर्जरी हुई थी, तो एट टाइम्स गेट्स हार्डर। अगर अच्छा प्रोस्थेसिस है, गैन प्रोस्थेसिस के लिए भी क्वेश्चन है कि डू वी नीड टू चेंज इट विद एज?
टाइम के साथ चेंज होता
तो
है।
सर ये बड़ा एक्सपेंसिव हो जाता है फिर उस सेंस में कि
एक्सपेंसिव है, इसी पे वो कैपिटलाइज कर रहे थे जो बनाने वाले हैं।
लेकिन वैसे कह रहा हूँ उसमें दो किस्म के आते हैं, एक कस्टम मेड है, एक स्टॉक आइज है। स्टॉक आइज वो होते हैं जो बने बनाए हैं, डिफरेंट साइजेस में है, जिस तरह आपको शू है या कुछ चीजें हैं जिस तरह आप पहनते हैं और वो कर लेते हैं, वो आप लगाते हैं और वो कर लेते हैं। तो यहाँ पे स्टॉक वो इतने बनाते नहीं है, स्टॉक में है ज्यादा इंडिया से आते हैं, इंडिया से क्योंकि हमारी इतनी बनती नहीं है, इस वजह से हम
कोविड में
इस
तो 50
सफर
खत्म हो गया था।
आते फिर भी हैं। कई जो कहते हैं कि हम कस्टम मेड बनाते हैं, वो स्टॉक आइज को लेके उसको ग्राइंड करके डाल देते हैं, वो भी करते हैं लोग। तो देयर आर डिफरेंट थिंग्स हैपनिंग इन द मार्केट, वो कई चीजें हैं उसके हिसाब से। लेकिन आप इंटरनेशनली मीटिंग पे जाए तो वो आपको पड़े होते हैं इंडियन वाले जो स्टॉक आइज उन्होंने रखी होती है, मैंने वो तो नॉट वेरी मैंने तो एक्सपेंसिव। लेकिन अगर यही आप यूके इंग्लैंड में जाएंगे बनवाने के लिए, $2,000-3,000 में आना शुरू हो जाती है चीजें उसके हिसाब से। लेकिन जो उनके कस्टम मेड है, हमने एक बार आई की मीटिंग में ओकुलरिस्ट को बुलाया भी था, वो अंदर इम्प्रेशन लेके फिर करके फिर लगाते हैं, तो टेक्निकली तो इट इज गुड, बट उसका इशू आई डोंट नो। With the years to come, 3D printing, I think it is going to overtake things. Time के साथ, if over time it comes in, so probably 3D printer आ जाएंगे, so then things might become easier in that sense and more economically for the patients and much better in that sense. जहां तक सेकेंडरी इम्प्लांट है, जब आप उनको इनिप्लिएट कर देते हैं, शायद पहले इधर मैं भी जब इनिशियली जब यहाँ रेजिडेंस यहाँ शुरू की तो सीनियर से वो कहते थे कि जो ट्यूमर है उसके अंदर हम इम्प्लांट ना डालें ताकि जब रिकरेंस हो तो फौरन पता लग जाए। तो ऐसा कोई इशू नहीं है आप उस लिहाज से। अब वो ये नोशन बहुत पुराना चल रहा है, जो पेरिफेरी में काम कर रहे हैं वो उस नोशन पे चलते हैं। तो वो कहते हैं हाँ जी ट्यूमर है तो इसमें आप इम्प्लांट ना डालें, उनको सॉकेट खाली छोड़ दें। तो अब क्योंकि कीमोथेरेपी एंड एवरीथिंग इज देयर, तो मैंने उससे कोई ऐसा फर्क नहीं पड़ता। वो इम्प्लांट दो किस्म के डाल सकते हैं, या तो आप स्फेरिकल इम्प्लांट डाल दें या पीएमए डाल दें, या सिलिकॉन है या मेडपोर है। दूसरा है कि डर्मिस फैट ग्राफ्ट भी डल जाता है। लेकिन ये सारी चीजें आप रेडियोथेरेपी से पहले कर लें तो इट्स इजियर, क्योंकि रेडियोथेरेपी होने के बाद काम बहुत मुश्किल हो जाता है, क्योंकि जो चीज है वो एवास्कुलर हो चुकी होती है, फिर बीच में वो ठहरती नहीं है और कुछ होता नहीं है। और उनका तो टिपिकल वो कंट्रैक्टेड सॉकेट दूर से ही देखे तो वो आते हैं, तो उनका बहुत ज्यादा फिर फंस जाते हैं उसकी वजह से। वेलकम खाजा सर।
थैंक यू वेरी मच।
Thank you so much, Dr. Salman. Ladies and gentlemen, the one advantage that enucleation serves over globe salvaging procedures is, of course, that it gives us a tissue diagnosis. Histopathology and histological staining, protocols, sections, everything is very important, and it certainly does help in achieving a better outcome for the patient. Let's hear it from Dr. Zanera.
Assalamu alaikum. I am Zunair Rathore, consultant histopathologist. I'm currently working at Children's Hospital, Lahore. And first of all, I would like to thank the ophthalmology department, Mayo Hospital, for arranging this activity and giving me an opportunity to be here. And definitely, this department needs to be appreciated for arranging this activity and bringing the pediatrician, the ophthalmologist, the radiologist, the pathologist, and oncologist on the same platform. So with that, I can begin with my today's topic, which is on actually the histopathological aspect, the protocols and the pathological staging. So listening here to Dr. Muin, I would pray that I receive less of enucleations with the advanced imaging technique, early detection, awareness, and the advancement in treatment modality. We hopefully receive less enucleations in future. So what I receive could be an enucleation, it could be a partial exentration, complete or other. It needs to be specified by the ophthalmologist. We don't need to fight. Homa is one of my colleagues from Children's Hospital, oncologist, fight in the MDT. It was exentration, it was partial, it was complete. I guess it needs to be, we don't need the exact details of your operative notes, but at least procedure should be specified because the pathologist is going to gross or see the specimen accordingly. Whatever you write, whatever you send, it needs to be grossed accordingly. So one more thing which was discussed over here before I proceed to the normal protocol, which we all are following nowadays over here. That is, in our country, still, we are not doing genetic testing, molecular testing, or prenatal examination of the patients. Although we know we have these tumors running in the families and the siblings and all that, but in future, we might be doing it with molecular departments in various universities and various institutions of Pakistan. The future lies with molecular testing. For that, we need to have fresh tumor tissue that is not supposed to be sent in 10% formalin, which we require for the biopsy specimen. And the important thing for that is we do measure the optic nerve, because with formalin fixation, it shrinks a bit. So we measure it over there. But here we need to create a window in the sclera by trifine or a blade, or we can aspirate the tumor through the sclera posterior to lens, and we get fresh tumor without necrosis. This tissue is used for identification of mutation of RB1 or other, whatever genetic mutation we want to check, because formalin fixed specimens don't do well, actually speaking. But this is actually the future from where I'm beginning. The norms which we carry out over here is that the surgeon must send me the specimen in 10% neutral buffered formalin, because if you won't send the specimen in formalin, it would be an autolyzed specimen. And all the heroic surgery, whatever you did, and the oncologist who's waiting for my report that would be needing the prognostic factors in the biopsy specimen, I won't be able to deliver that report. And the patient is the sufferer, actually speaking, with just a bit of negligence, not putting the specimen into formalin. So you should be sending it, you should be sending it in formalin. Then other thing would be that volume of fixative is again very important. That is, we have a ratio of 1:10. Usually eyeball is a small size specimen. At least the container should be this big so that you can fill it with formalin with a ratio of 1:10, and the formalin should not be filled the container full, because to avoid spillovers. So that's again a hazard. So it is a ratio of 1:10. Other important thing is that we need a fixation of 48 hours. Usually with mucosal biopsies, endoscopic GI biopsies, it could be 4 hours. With uterus and stuff like that, it could be 12 hours. Here we need long fixation because it's a semi-solid sort of a thing with us, just going to trickle away. So we need a longer fixation. So this report is not going to be delivered within 3 working days, which you usually claim we send out the report in 3 working days. So that's important. We need a longer fixation, because previously, once we used to be residents and students at KE, it used to be, we used to put the eyeball in the freezer. That creates freezing artifact. We don't recommend it anymore. So we need to put it for a longer fixation, it gets fixed, and then you can do the crossing and carry on with it. Specimen needs to be properly labeled. Even Dr. Salman mentioned it, that if you're sending me, you have the muscle or anything along, you need to label it with the sutures. Preferably, you should label the optic nerve also. Nowadays, surgeons are too kind to take on a longer chunk, and obviously everybody can appreciate, but otherwise optic nerve can also be labeled. Anyways, and next is to fill the form properly, the procedure done, and radiology department has done its work prior to your treatment and your enucleation, and then sending it to me. If you write the report and they say they see optic nerve involvement, then at times I have to exhaust the tissue to see optic nerve involvement. And obviously, ultimately, histo will remain the gold standard. Either I'll report it or I'll say it's negative. But then even if you will mention it, that will be very helpful to the patient. And then radiological, pathological correlation, they go hand in hand. It's a teamwork. So form needs to be properly filled apart from the normal things you mentioned. If you mention any pre-op chemo given or not, and radiological findings, you're not going to copy the report, trust me. So a few people think that whatever they'll say, I'll copy. I can't copy that. We have our own domains to do. And if I move on to histopathology of retinoblastoma, the enucleated eye is inspected externally. Any extraocular tumor nodule, any scleral discoloration, optic nerve thickening, and length of the optic nerve is to be documented, because that's what is always required by our own in-house oncologist. She makes it a point that there should be an adequate length of optic nerve, which is supposed to accompany the specimen. And I always fight back that what ophthalmic surgeon is sending me, I can only report that much. I can't make it on my own. And then for the grossing, obviously, we see the corneal diameter, the AP, horizontal, vertical diameter, length of the optic nerve needs to be documented for them, clarity of cornea, pupil, and iris. And obviously, we do macroscopic examination over here, in which we can say we cannot determine the site. It could be supratemporal, it could be supranasal, infratemporal, anterior chamber, any other that needs to be specified in the report. And this is how we take a blade and we really go through it and we put it into 3 slabs: the vertical, the horizontal, the oblique are the diameters. This is how we take the 3 slabs. Here we have the optic nerve, and this is actually how we do it. We chop off the optic nerve. Few, I don't know, surgeons, they send the optic nerve separately, and we have it along the globe also. That is very important for the pre and the post laminar tissue. Then once we have taken it into these 3, the middle slab, the upper and the lower, this slab again is put like this into hand, and then it is seen under the microscope. Now, this photograph actually how the ophthalmologist sees, how the radiologist, and how the pathologist sees. Everybody has their own things which they want to see and on which they want to report, and each one of these have its own prognostic significance. So in microscopy, apart from everything else, if there are more than one cause of the tumor, I'll mention the size, the location, calcification, the pattern of growth, seeding in vitreous cavity. If retinal detachment identified, it needs to be reported in that report. And then there are certain things, although with so much advancement of radiology that we know the diagnosis prior to obviously enucleation, there are certain things which are still there on pathology to be reported. They are the high risk factors. That is anterior chamber seeding, iris and ciliary body infiltration, choroidal infiltration, optic nerve invasion. This is the biggest fight between us and the oncologist. Then scleral, extrascleral extension. They all need to be incorporated into the report. Optic nerve involvement, obviously, at times we used to say cannot be determined. Now we make an utmost effort. We have to exhaust the block. It should be there. No eye can be enucleated without the optic nerve. It would be there. At times you don't get longer lens. That's a separate issue. And then there could be none. Then anterior to lamina fibrosa, which obviously has a better prognosis at lamina fibrosa still. Posterior to lamina fibrosa, but not the distal end of the nerve, which is actually the surgical resection margin. And this is where we put into PT4, cut end of the optic, if that is involved, which is going to be a poor prognostic factor for the patient, definitely. And this is this photograph has been taken from the internet. I didn't get the time. We in-house, we get lots and lots of retinoblastomas, but this is a photograph which has been taken from the net. Now here, tumor is lying over here. This all is pre-laminar. In the next photograph, it is lying over here also. So this is here, it is post-laminar. And if I label it for you, you can see the optic nerve head, pre-laminar, lamina fibrosa, and post-laminar over here. So we need to comment on all this. At times we get a bigger slab, we have to cut multiple levels to see the invasion. In the first level, at times we are unable to get it, but on deeper levels, we are able to appreciate it is post-laminar. And this should be done because this is going to make a difference for the prognosis of the patient and for the oncologist in the treatment. And then we need to comment on choroid invasion. That's a mandatory thing to do. It could be a minimal choroid invasion if less than 3 mm, or it could be in thickness or in the horizontal diameter or horizontal length, or in other case, it could be minimal. Both need to be reported because it's going to pathologically upstage the patient's report. Microscopically, we do the grading also. And this grading, obviously, poorly differentiated will have a poorer prognosis in behavior, and well-differentiated behave well. Personally, I have never seen retinocytomas in my experience to date because they are with neuronal differentiation, but they don't have karyorrhexis or abnormal mitosis. I've never encountered it in books we have seen. On internet, we have seen, but the patients who present to us usually present with high grade and late stage of tumor. And obviously, the G2 tumors will have many rosettes. flexner or homerite, but many over here. Then in G3 become occasional, G4, this is fully differentiated without rosettes, and it's more of a round loose cell tumor with more of an anaplasia. And if the grade cannot be assessed, we have to put GX. If it's fully preserved, you didn't put it in formalin, I can't make it out because the morphology is due to autolytic changes rather than a true morphological picture, which I should be reporting. We don't report that. So this is how the rosettes look like. These are the tubules overhead. Flexner and the homerite rosettes are the one. These are again the flower-like rosettes, but they have a fibrillary material in them. All neuroectodermal tumors have these homerite rosettes. It could be Ewing's. It becomes very difficult for us to differentiate between retinoblastoma histologically and Ewing's. We have to go for translocations. Morphologically, it becomes impossible at times. So if we move on to the pathological staging, this is not the clinical staging, not the groups done by Professor Hakan. This is pathological staging, which again has its own prognostic implications. That is, I'm just going to do brief of it. That is, primary tumor cannot be assessed, and there is no evidence of primary tumor. In PT1, it is confined to the eye with no optic nerve or choroidal invasion. In PT2, minimal optic nerve, that is, it is pre-laminar or laminar, and choroid invasion is there. That's also minimal. That is less than 3 mm. It's minimal. And then PT3, significant optic nerve, it's post-laminar or choroidal invasion massive, which is greater than 3 mm. And if I move on to PT4, that is optic nerve resection margin is involved or extraocular extension elsewhere, but not both. So these are the further minute details of PT2, which we divide into 2A or 2B. That is, if I said in 2, there is optic nerve head, but does not extend post-apical lamina cribrosa, or this or over here. In our student life, I used to say they've written the same thing. Why are they telling me 1 and 2? Till the time I realized here it is or. Tumor exhibits focal choroidal, but not both. If it's both, then it's PT2B. You can have both also. So for a very long time, I used to fight that this is a misprint. They don't know how to do it. Once we were students, but now I know it's not a misprint. In PT3, tumor with significant optic nerve or choroidal. And again, over here, it's or in 3A and both in 3B. And PT4, obviously, we said if the resection margin is involved, then it is PT4. Similarly, we have regional lymph nodes, which usually are not accompanied, but it is NX cannot be assessed, no regional lymph node, and N1 is regional lymph nodes, and N2 distant lymph node involvement. Usually, we don't get nodes with our enucleation specimen. Mets, we all know, could be no metastasis to sites other than CNS. Then it, or depending, single, 1A, multiple, 1B, CNS Mets, 1C, 1D is discrete masses without leptomeningeal or CNS involvement. And then there could be leptomeningeal or CSF involvement. This is how we grade it that way. And if the form has been properly filled and we know treatment has been given and there's necrosis, there's residual tumor, a prefix of Y, because this was pathological. This was not the clinical. This is the clinical. Use CTNM. It could be clinical staging, which you guys are doing. A prefix of Y is added. And this is the pathological, which we are doing. We need to put a Y prefix and then we do the rest of the staging as we have done it before. And if you have any questions, we can ask. And in the end, I would like to add, it's a teamwork which has to be done by the pediatrician, by the ophthalmologist, radiologist, pathologist, and obviously the last one we hand over to our patient now with pre-chemo, we hand them over before also, our oncologist. And definitely alone, we can do so little. Together, we can so too much. Thank you so much for your active listening. If you have any questions.
Dr. Sunera very comprehensively covered the topic. I have one question. What about the skip lesions? We have recently been seen the relapse in our patient. And when we go back to the histopathology report, we found that it was mentioned in a couple of reports that there was a post-laminar extension of the tumor, but the cut end is free. Is it important that we could find the distance between the last tumor site and the distance between the cut end? That length, if it's
Okay.
like, is it
Okay.
a possibility that?
No, I can tell you, we receive an eyeball like this, and here we have the optic nerve over here. Once the distal end of the optic nerve actually is the resection margin, and we can have skip metastasis for any tumor in the world. So what we do is, once this is the optic nerve, this is the optic nerve. This is the distal resection margin. I put it in a cassette, first of all, in order to avoid, because if I'll cut the tumor first, then I can contaminate the knife and I can put it there also. And that would be actually a false positive result. So I put that in a container and that is run. This is the resection margin. Rest of the nerve, I can take more section to rule out skip metastasis. You can have so. And then this is the eyeball left behind with this portion of the disc of the eyeball over here. Okay, so now this was to be transected into three, like this: upper slab, lower slab, middle slab. One of the slab has this optic nerve with it, and it is over here where I label this is pre-laminar, which has got a better prognosis. This is laminar, still good, and this is post-laminar. Now you can have post-laminar involvement, but at the same time you can have the distal resection margin of the optic nerve free. That's very much possible. Usually, initially, we used to fight with the oncologist के आपने post laminar दे दिया, आप उधर free लिख रही हैं, ये दो फर्क वो हैं, वो PT4 है, the distal end. That is the जिसको हम with the surgeon we say this is the surgical resection margin for you, just like the ureter. Here, the optic nerve also carries the same implication, goes to PT4, which is a poor prognostic. Post laminar is PT3. So we don't need to measure the distance. That's not going to make any difference to the treatment of the patient, actually speaking. But definitely, 4-5 days back, I received a biopsy. It was metastatic retinoblastoma. Patient had retinoblastoma, had been treated, but definitely we are still fighting between saving the lives and saving the vision. So it's a long journey to go together. Definitely we can.
Okay, another one from our end. What do you think that if we draw for you the diagram to tell you that the main tumor is over here, so would it give you any would that be any different?
It does. It does.
Take the cut section.
It does. Actually, we are a country with economic restraints. We don't do imaging and find the tumors. We don't do, to be honest, trans-elimination test for seeing the tumors. So that's why we said you have the imaging modalities done before. For post-chemo, it's going to be different. For anybody who has not been given chemo, at least if you don't want to share the images, share the report with us. At least if you are sending us a specimen, label it with sutures. Because anybody, once it's out, you can't put this is left, this is right, until and unless you have labeled it properly, and that lies with you guys. So that's really going to help. Obviously, it does help. You can measure the distance, you can ink the margin, you can tell the distance, even if it's free, it's close, obviously, that helps the patient. That would be a great help.
Thank you.
Thank you so much.
मेरा क्वेश्चन वही है जिसपे मैं आपसे चिल्ड्रन हॉस्पिटल में
My
बहस कर रही
answer, I went there to see him.
if we do not get an optic nerve of adequately, which is not 1 to 1.5 centimeter, then what are the chances of relapse? Because based on cut and is not involved, we are not going to upstage. Our risk stratification accordingly, it remains the same. So Dr. Lima,
I would like the ophthalmologist to actually comment on this, because this is the biggest fight. He's a good friend of mine, between me and Homa. How can you put a patient or upstage a patient, ophthalmologist then give me 10 mm of the nerve? Why should the patient suffer actually? To get XRT. So actually in the literature, it doesn't say, the ophthalmologist doesn't send you 10 mm of the nerve, so you can put the patient to XRT. That's a fight between the ophthalmologist and the oncologist. So किसी का बच्चा होता है, उसको over treat. I didn't find any reference in the literature कि अगर optic nerve 10 mm से कम आती है तो उसको XRT लगा दो. I didn't find it. So I need the ophthalmologist actually to comment on to it. So Dr. Halima, you're working at Shaukat Khanum.
Sir, हमारा
Sometimes we get enucleated samples. Maybe मैंने की हो, मुझसे 2 millimeter optic nerve निकली for whatever reasons. ठीक है, अब वो 2 millimeter optic nerve निकली, मैं नहीं ज्यादा लंबी निकाल सकती.
अब जब वो इनके पास हिस्टोपैथोलॉजी के लिए गया, इन्होंने देखा 2 मिलीमीटर पर ट्यूमर था। अब वो तो डिस्टल मार्जिन पॉजिटिव आ गया, वो स्टेजिंग उसकी अप होगी। सो क्या हो सकता है उसके 10 mm पे दे माइट नॉट बी अ ट्यूमर, तो उसके अंदर शुड बी अपस्टेज द पेशेंट एक्चुअली, और हाउ शुड बी डील विद इट? क्योंकि दिस इज एक्चुअली हैपनिंग कि ऑप्टिक नर्व का नंबर सेक्शन नहीं निकल सका। ऑप्टिक नर्व एक दफा नहीं अच्छी निकली तो उसका क्या?
Yes, literature से
एक तो ये कि प्रोबेबली जिस तरह आप कह रहे हैं कि निकल आया तो फिर तो ट्रीट उसके हिसाब से ही करना पड़ेगा।
I'm sorry
लेकिन
for that patient, we didn't get it. We did extensive surgery for the orbit. Again, for that patient, there was no tumor, and that there was thickening on radiology, and which said let histopathology decide. So the patient went another surgery, and there was no tumor in that also. There was no tumor for that patient. I remember vividly.
but by that time, how many chemo cycles the patient had already? Yeah. Because what the literature says that if it's a cut end, even if the size is small, then you need to upgrade the thing. It's the literature
That's not the
evidence.
Issue is when the
But the
optic
thing
nerve.
is that before the second surgery, how many chemo cycle has already been given? Because that can cause the
Which was free.
I think we should all stick to the protocol actually, and this type of patient needs to be discussed in the MDTs and to be decided individually.
उसमें ये कि probably the best thing to do it जिस तरह enucleation करते हैं, residents are interested in doing stuff, उसमें they can identify the muscles and everything, but when it comes to the nerve actually being taken to the senior consultant on board, he should be there. और मैंने होता अगर किसी को training में को feel करता है there is a gap, तो you can always fill in so that आपका अगर बार-बार आपके oncology से if you're getting a feedback कि the section is short, तो आपको भी feedback भेज देना चाहिए कि आपका issue है तो इसको probably please mention it कितना है, लेकिन pre-op भी आप you can check उस पे MRI पे कि how much is it involved or not. अगर involved है तो get a marking कि कितने तक involved है, you have to get it by 10. अगर नहीं लेंगे तो इसको बीच में कट जाएगा, तो MRI से probably आप सब क्या कहते हैं पता लग जाएगा ना कितने mm तक है।
ऑप्टिक नर्व को कमेंट करने के लिए हमें सिंपल थिन स्लाइस टारगेटेड इमेजेस थ्रू द ऑप्टिक नर्व चाहिए होते हैं। इस तरह अभी मैंने आपको कुछ इमेजेस दिखाई भी थे। यूजुअली प्रॉब्लम उस वक्त आता है रेडियोलॉजी में जब वो ऑप्टिक नर्व के पैरेलल स्लाइस प्लानिंग नहीं है, वहाँ ऑप्टिक नर्व को कमेंट करना मुश्किल हो जाता है। डिजीज का प्रेजेंस और एब्सेंस, अगर प्रॉपर कॉन्ट्रास्ट एनहांस बैड सप्रेशन 2 मिलीमीटर स्लाइस थिकनेस सैजिटल एंड एक्सियल दोनों लिए जाएं तो प्रोबेबली कोई केस मिस नहीं होता। प्रॉब्लम सिर्फ इमेजिंग टेक्निक का है, और मैंने ऑलरेडी हाईलाइट भी किया था कि ओपन एमआर सिस्टम में यूजुअली वो कैपेबिलिटी नहीं आती, डिजीज मौजूद होती है। 2 मिलीमीटर की थिकनेस को या इन्वॉल्वमेंट को पिक करने के लिए आपको स्टैंडर्डाइज प्रोटोकॉल अप्लाई करने पड़ते हैं। अगर वो अप्लाई होंगे तो फिर ऑब्वियसली ऑप्टिक नर्व इन्वॉल्वमेंट मिस नहीं होती। थोड़ा प्रॉब्लम ये है कि कुछ हमने केसेस जो ऑलरेडी हम रिव्यू करते हैं रिट्रोस्पेक्टिवली, तो उसमें सिर्फ इमेजिंग टेक्निक का फर्क। Otherwise, MR is quite capable of identifying the optic nerve involvement. At least जो उसका initial 4-5 millimeter का distance है, उसमें कभी भी problem नहीं।
जी डॉक्टर हुमा।
आगे खींच के तो then you go in and cut the optic nerve, लेकिन एहतियात से कि आप lid ना काटे या कॉन्ज ना काटे, लेकिन that is probably one way, but you learn with time कि कौन सा आपके लिए बेहतर है, but that is one way of doing it. और अगर आप लोगों को feel होता है तो मैं मतलब you can always modify your ways and try to get.
I think our next part and then we can after also treating the cycle and see where we are not participating that we get a good response to chemo and optic nerve involvement on MRs is reduced, and then we go for surgery. So it gives us a better chance of एक तो कीमो के कवर के साथ आप कर रहे हैं, दूसरा आपकी, लेकिन उसका नुकसान ये होता है कि वो डाउनग्रेड करता है स्टेज और जी जी बिल्कुल जी जी। तो जनरल प्रैक्टिस हमारी भी यही है कि प्री इनिकुलेशन हम 2 कीमो साइकिल्स देते हैं, देन गो फॉर सर्जरी। बट अगर आपकी 10 मिलीमीटर की नर्व इन्वॉल्वमेंट है ऑन हमारा टू बिगिन विद, व्हाट डू यू डू देन? तो 10 है 12 है 1.2 जी वो तो है ही कीमोथेरेपी, आई नो दैट, लेकिन
ये क्वेश्चन है
जी तो हम
ये
चार
क्वेश्चन है
दैट व्हाट आई we increase the chemo cycle, we reduce the MSH before good. And we monitor the optic nerve involvement repeatedly.
I have a question over here. How many of skip metastasis anybody has seen? It's a dilemma, I guess. This is the right forum to say we should have a retinoblastoma registry. At least patient, you are the biggest institute, I guess, where I'm standing right now. If all the retinoblastoma patients are registered over there, we'll have the diagnosis, we'll have the radiology, and we can bring a change to that also. I haven't seen much of skip metastasis. Obviously, they are there. They are reported. They are rare, but they are there. But actually, I think we don't have a retinoblastoma registry, which should be there, which is going to help us all with all the future.
Sorry, मैं आपकी बात काट रही हूँ, हमारे पास टाइम थोड़ा सा वो हो रहा है. Further questions we will take at the end of the session, please. I would like to invite Dr. Iftikhar, वो उन्होंने जाना है, एग्जाम ले रहे हैं. I would request कि वो प्लीज आए और हम अपने व्यूज हमारे साथ शेयर करें, खास तौर पे ऑन्कोलॉजी पीडियाट्रिक ऑन्कोलॉजी सर्विसेज के ऊपर जो वर्कलोड है उसके बारे में हमें एनलाइटन करें और उसको कैसे हैंडल किया जा सकता है. थैंक यू मैडम.
Thank you very much, Dr. Shavana, for inviting me. And Assalamu alaikum, all faculty. If any students here, I could see few postgraduate residents and a few faculty members from outside, like Professor Abid from Children's Hospital. I'm really happy to see Dr. Mavish, very busy oncologist from Children's Hospital. I have actually very long association with all these members because I had the privilege to work with all this team in Children's Hospital as well and had a wonderful experience. Anyhow, मैं तो डॉक्टर शबाना और सारे बहुत लर्निंग लोग बैठे हैं और माशाल्लाह दे आर डूइंग वंडर्स. तो उसमें शायद मैं कोई ऐसा कोई बहुत बड़ा इनपुट आपको नहीं दे सकूंगी और ना ही ये मेरे आने का पर्पस है. Only sharing with you that Alhamdulillah, with the blessings of Allah Almighty, probably our unit is the second busiest unit in handling retinoblastoma cases in Lahore after Shaukat Khani. और अभी बर्डन इतना बढ़ गया है इस डिजीज का कि एक तरफ तो इट्स वेरी सूदिंग दैट पीपल आर कमिंग, वी आर ऑफरिंग इन आवर लिमिटेड कैपेसिटी व्हाटएवर डूइंग मैक्सिमम. एट द सेम टाइम ये है कि कुछ चीज़ों में बहुत एप्रीहेंशन और प्रॉब्लम आता है व्हेन वी आर नॉट गेटिंग कीमोथेरेपी मेडिकेशंस और जो हमें सब चाहिए. हमारे साथ जो बहुत एक हेल्पिंग हैंड है बड़ा, वो पीडियाट्रिक रेटिनोब्लास्टोमा टीम from this department And the credit goes to all the seniors, obviously, who are having very, very positive attitude and letting even their juniors to do what they want to do. अगर हम statistics की बात करें, over the last almost 4.5 to 5 years, we catered like 194 retinoblastoma cases. उसमें से 16 patient got expired, जो obviously बहुत advanced disease थी उनकी, और 10 patient got lama. अब कोशिश करते हैं और ये हमारी almost daily basis पे बात हो रही होती है. Whenever I see the whiteboard and I ask why this patient got lama, fortunately, alhamdulillah, very few get lama. उसके बाद भी हमारा इस चीज के ऊपर बार बार ये डिस्कशन होती है कि no patient should get lama if the family circumstances or compelling condition उसको मजबूर करती हैं कि नहीं घर जाना है, या कुछ ऐसे circumstances हैं, they don't want to proceed for further management and treatment options, तो आप उनसे discharge on request लिखवाओ. उसके दो फायदे हैं. एक तो he will be carrying that discharge slip जिसके ऊपर clear आपकी description होगी. God forbid any complication on the way or anywhere happens, at least जो attending pediatrician है, physician है, whosoever, उसको पता होगा कि ये क्या case है और मैंने अभी करना क्या है. They may save their life. This is not only for retinoblastoma, for every patient this holds true. और दूसरा, probably it carries a negative impression किसी हद तक कि शायद patient को educate नहीं किया गया, उसको सारी चीजें बताई नहीं गई कि वो चुपके से भाग गया और लामा हो गया. ठीक है, तो anyhow ये चीजें चलती रहती हैं. Being the busiest hospital, new hospital, बड़ी लंबी इसकी history है. And I was being trained here as registrar, then SR, then AP. और जब मैंने step in किया associate professor की post पे, then I went to children for a few years, and again it's very soothing for me that again came back to my own home. So retinoblastoma के हवाले से I would rather request Dr. Shabana and the whole team कि अगर हम इस तरह का कोई symposia या कोई activity arrange करें जिसमें we need to take on board family physician, general physician and general pediatrician, for the reason being कि कुछ alarming sign है like white pupil or bigger pupil or red painful eye, or maybe patient is keeping his head in a tilted manner, या उसकी आपको लगता है कि squinting है, तो ये early sign है. Before we miss them, उसी वक्त वो लोग refer करें proper setup पे, बजाय इसके कि when it is too late it comes to you, और फिर आप अपने sincere efforts के बावजूद बाज़ दफा वो outcome नहीं ला सकते जो early detection से होता है. ठीक है, with this I'll stop here. Thank you very much once again and carry on.
Thank you so much, madam, for joining us. Now to hear a very summarized view of what Pakistan Society of Pediatric Oncology advises regarding retinoblastoma management, I request on stage Dr. Halima from Shaukat Khanum Hospital. Dr. Halima.
Assalamu alaikum, everyone. Thank you so much for this opportunity to represent PSPO, which is the Pakistan Society of Pediatric Oncology, on this forum. I'll be putting my slide. Thank you. So I will basically be talking about our national retinoblastoma protocol, which is being conducted by the Pakistan Society of Pediatric Oncology. I'm not going to go into any of the details of the treatment because I think we've covered all of that today, you know, in the different portions. The point of my talk really today is to, sort of emphasize the need to do research, to work together with all the subspecialties and move forward, and what we are trying to achieve as a society at this point, and how, you know, everyone can, you know, work together and work more on this. So we have a national standard of care protocol for the treatment of non-metastatic unilateral, can we go back to the first? Retinoblastoma, which has been open since 2001, and we're actively enrolling. I'm a pediatric oncologist working at Shaukat Khanum Hospital right now, and that is one of the centers that's enrolling on this protocol.
Pakistan Society of Pediatric Oncology is essentially a national society for the care of children with childhood cancer. So it is not just for oncologists. We have pediatric surgeons that are members. We have a strong nursing group. We have radiation oncologists. And I think it'll be awesome to have pediatric ophthalmologists on board as well, because retinoblastoma is a major pediatric malignancy that we deal with, and we can only take care of it as a team. So I would welcome everyone here, and I would really urge you guys to encourage all your colleagues to become members as well, so that we're all on the same forum for this. The vision of our society is to provide accessible quality cancer care for every child and adolescent in our country. So retinoblastoma is a case of global disparity that is really stark. There's 100% survival in high-income countries. And I think earlier today, one of the speakers here talked about how the first time they ever saw a retinoblastoma case was in their first prof. I'm a pediatric oncologist. And the first case I saw was when I came back from the US to Pakistan. So my entire pediatric training, my experience in oncology there, I actually never had to take care of a patient with retinoblastoma because they were picked up so early that they were all managed by the ophthalmologist. They never needed chemotherapy. So I actually was not a primary on any retinoblastoma patient before coming to Pakistan. So this is really close to my heart because I've seen it where there's 100% survival. And when we see kids dying from it, it really hurts me. So it's a passion for me. So, this is where we should be picking it up as leukophoria, as we've talked about earlier. And this is what we practically continue to see in Pakistan. So I'll just share a little bit of the PSPO journey in retinoblastoma. So in 2017, in our working group committee, we made a decision that we should develop national guidelines so that we are all on the same forum and treating retinoblastoma the same way. And as a result of that, we had our first meeting in Lahore in 2018. And Dr. Seema Qayyum was here earlier. I think she's left. She really helped to organize that. Dr. Shambhal was involved from the oncology portion, and Dr. Shabana was there. And I think many of the people here attended that. And that's where we came up with the concept of developing national guidelines. And this resulted in 2019 in publication of the first national treatment guidelines for retinoblastoma. And I think many centers in Pakistan are now utilizing it. Moving on from this, what happened in 2018 was WHO announced a new initiative to reduce to increase survival, like not reduce, to improve survival to 60% in children with cancer across the board. And 6 malignancies were chosen as target. And retinoblastoma is one of them, because again, because of the global disparity, we have a chance to improve survival in this. And so this is known as GICC, which is the Global Initiative for Childhood Cancer. And Pakistan is now one of the target countries for WHO for this global initiative. Under this, PSPO applied for a grant and got a grant to develop national guidelines for the 6 target malignancies. And under this grant, we developed this national protocol. So in 2021, this team was created for the development. I'm the principal investigator, and we had participation from major oncology centers all across Pakistan. And we also included co-investigators from all the subspecialties, including ophthalmology, radiation oncology, pharmacy, histopathology, radiology, for their input for developing their specific sections. So the key timeline in this is that we submitted this to NBC in 2022, and by June 2022, we had NBC approval, and REDCap was the internet format that is being used for this, and that was in October 22, and since then we have been enrolling. The aim of the study is to diagnose and treat children with retinoblastoma according to a standardized protocol at all institutions across Pakistan, resulting in a greater accuracy in diagnosis and improved survival. So that's the aim of our study. Patients that are eligible they need to have a confirmed, obviously, diagnosis of retinoblastoma, and it can be on EUA. They need to be less than 18 years of age. They have to be previously untreated at the time of enrollment. Some that have received focal therapy
or if they have had enucleation at a center outside the enrolling center, they can also be enrolled, because obviously we get a lot of patients with enucleation upfront. And obviously informed consent has to be taken for enrollment. This is the treatment schema. I'm not going to get into the treatment because we've already discussed the treatments, the chemotherapy, and I think all of that has been covered. So essentially it has an intraocular protocol and an extraocular protocol. We probably need a whole day just to go through all the details. So that's not the point of my talk. It's just to know that it's there. But the most important thing I think in this protocol is that it includes a very detailed review of pathology guidelines, radiology guidelines, radiation oncology guidelines, and enucleation guidelines, which are all things that we've talked about today, and they are all in this protocol. So if all of us in our hospitals can implement these, share these with the relevant departments in our hospitals, we can have this reporting on a uniform format. So for example, for pathology, right now we heard about all the guidelines, they're all included in the protocol. We need to open it and share it with the relevant departments. So they're all reporting on the same format. Same thing for radiology. Even, the radiology guidelines and, what MRI to use, what the power should be, all of that is in there. And each subspecialty works very hard to come up with the latest standard of care and put it in there, and also to make it relevant to Pakistan. So it's based on what is available here, not what the US recommends necessarily. It's what we can do here. And so I think that's a really important aspect of it. Right now, the centers that are enrolling are listed there. There's 2 in Lahore, Children's Hospital in Shaukat Khanum, Karachi, there's 3 centers, Islamabad, PIMS and CMH, and Multan. Faisalabad has also joined recently. That was before I made the slide. So after the slide was made, and they have not enrolled any patients as yet, but they're part of that. I would like to invite everyone that's here to join this protocol. It involves having a principal investigator at the site, and you need IRB approval obviously from your institution, and we have a central office, and I'll share the emails who can help you with that. So you need to contact them and identify who the team will be, and you can start enrolling at your institutions. Currently, we have 106 patients enrolled since up to June 2022. This is over a year. And those are the individual centers that have enrolled patients. I just want to, and this is our enrollment forecast. So we plan to run it over 2 years. Our target was about 200 patients. I think we're almost halfway there. We have 100 patients already. And if we continue to enroll at this pace, this is where we would be. So the blue line is where we are right now, and the red line is sort of projected. If we continue to enroll at this pace, I would hope with meetings like this, more collaboration and more centers joining, we can enroll even quicker than this and reach our target even faster. So really, in conclusion, we need national monthly institutional studies to improve outcome. Till we know what we're doing, we don't know what we can do better. So we really need to know where we are and move forward with that. And we need participation from everyone here. I would welcome everyone to come on board and take part in this. I just want to address the registry question that was raised in the last, because I didn't get to answer it in the question answer session. So this is not a registry, obviously, but the more institutions that are involved, and retinoblastoma is a very specialized thing, so it is treated in specific centers. So if all the centers participate in these studies, we will get the data for most of Pakistan. The other registry is, at least for Lahore, but Punjab Cancer Registry is very active. At least every child that has any enucleation gets registered, because we work with all the labs, so any enucleation specimen that's reported is on that registry. So that at least in Punjab Cancer Registry is capturing every enucleation. But the ones that don't get enucleated or don't come to either Children's Hospital or Shaukat Khanum, probably, or even Jinnah is also part of Punjab Cancer Registry, they don't get picked up. So again, Mayo Hospital is a huge institution. It's a part of Punjab Cancer Registry. we're active on it, trying to, so we, all your retinoblastoma patients that don't make it to surgery, which we hope will be more and more patients, will be on the registry from the clinical enrollment part. So that's something definitely that we can work towards in terms of the registry. So I'm just going to leave this email. These are our people at our clinical research associate and our trial coordinator at the PSPO head office in Karachi. And you're welcome to contact them if you want more information on the study and if you want to become part of it or anything else. Also for becoming members of PSPO, because if you're a member of the same society, that helps us work together. And again, I hope we continue to have these meetings in Lahore. We really need to work towards a citywide tumor board as well, that I think Huma's been working very hard to coordinate. I know all of us attend the Karachi tumor board, a lot of us do, but we need to have one for Lahore as well. So I think that's another thing we can move towards. So that's just like a brief intro to our current protocol that's running. I'd be happy to take any questions.
I just want to add one thing. हम बहुत जैसे try करे थे. I think for last 6 months we've been trying to get connected to Mayo team. कि हम उनको study में enroll कर सके. The only problem we have so far is you don't have an MD team for retroblastoma. इस study में enroll होने के लिए you have to have a histopathologist, someone from the radiology department, and someone should take from the pediatric oncology and from ophthalmology. For example, we have Dr. Shabana. So I'm so sure you have people from pediatric ophthalmology department as well as from pediatric oncology. But I think you need to establish a team from your histopathology and radiology as well, because that's a very detailed information we have to put in to be a part of the study. So, और MDT के लिए you guys are always welcome. हम तो हर महीने plan करते हैं कि हम एक MDT start करते हैं, तो we need to your cooperation in that context.
Yeah, so I think a citywide MDT would be very nice to work towards.
I am Professor Khwaja Khalid Shuaib, basically ophthalmologist. I did my fellowship in pediatric ophthalmology from Sydney, Australia. And I stayed there for many months and I did not see a retinoblastoma more than 1 millimeter or 2 millimeter in size. You see, and that was because of that was because of the extensive follow-up that they do for the cases who are liable to have recurrence, especially bilateral cases and whose parents have been treated. So 1 millimeter or 2 millimeter. And here in many institutions, in clinical meetings, cases are sort of presented that one eye has been enucleated and the other eye is full of tumor. And so what should we do the treatment? I mean that the stage has gone where we can treat. Why can't we sort of prevent the occurrence of the tumor in the other eye? And the thing which where we are lacking is extensive follow-up. So I just want to add from your knowledge. So what is the chromosomal analysis being done here to identify the familiar chromosomal mutations?
Okay, so we don't have the genetic testing for retinoblastoma. At AKU, you can, AKU sends it out, but you cannot send it to a collection center. You need to meet the genetics team at Khan University, Karachi, and then they will send out the test. But I think if you have, if you have a strong family history, if you have bilateral tumors, if you have multifocal tumors, there are things clinically that will let you know that this is going to be hereditary. So those are things that can sort of alert you. And essentially, because we don't have genetic testing available at this point, even for our unilateral cases, we follow the contralateral eye very, very carefully. Because we don't know, especially the kids that present early, less than 1 year old and so forth. We are, very regular with the EUAs and follow up to make sure that we don't miss a lesion in the contralateral eye. We also work very hard to convince the families to get the rest of the family members screened, even for unilateral RB. We give them referral letters, repeatedly send them out. Unfortunately, again, this, a lot of them can't bring all their children to Lahore, for example. So we'll give them letter for their other 5 or 6 children at home, and they'll take them to a local eye doctor who will not do any EUA. They will just, look at the child's eye and they'll say, doctor saab ne dekh liya tha, bata diya, sab theek hai, koi pareshani ki baat nahi. So that's the problem. So I think that's where we need education at every level, so that when we send someone with a letter for an EUA, they actually get an EUA done. Then you to send them back and say, no, tell them, put the child to sleep and then check their eye, and so forth. And again, there's limitations in the system. So that's how we're trying to handle it, is at least the cases that come to us, we screen the families and counsel them accordingly. The early detection, even in the West, it's not through genetic testing though, it's through early detection programs, which are linked with vaccination programs, and it has to do with regular well checks and making sure you check for white reflex at all the well checks. So I think at that level is where you can do the early detection more than at a genetic level.
So how might this histological features affect the treatment? You see, if we see the rosettes, for example, will it treat practically the management?
So the extent of disease extensively affects the management. So, there's very specific, well-defined risk features which define what kind of chemotherapy you're going to give. So if it's not a very invasive tumor, usually you can just do enucleation. But then if choroidal invasion is present or retrolaminar nerve invasion is present, which we really rely on the histopathologist to give us accurate assessment, then we give chemotherapy. And again, if the cut end is positive, in that case we give chemotherapy plus radiation, and the outcome is very dependent on the histopathology. So for upfront enucleation, histopathology is very, very important and really helps us in decision making. I do want to address the question that Huma had earlier as well, since I have the mic, just for 1 minute. So that is also defined on the protocol. So if the cut end is positive, regardless of the length of the optic nerve that was obtained, you have to give radiation. And if it is negative, regardless of the length of the optic nerve, you don't have to give radiation. I mean, you may miss a skip lesion, but we'll never know that. Even with 1 centimeter, you could miss a skip lesion. You can't know a skip lesion, right? And the other thing with the upstaging with the optic nerve, again, that's one of the things that we worked very hard with the radiologist to define, is what we would call extraocular on MRI. It has to be optic nerve thickening more than 2 millimeter. Not just enhancement. And if that is present, then we call it extraocular. We treat it more aggressively with pre-op chemotherapy, and all of them get radiation, because what's been seen is that when you give these children less chemotherapy with just chemotherapy, enucleate, get a negative margin, they relapse later. And that's been reported in the literature that the outcome is worse. So you end up downstaging the patient by giving chemotherapy. And then, so if you have decided upfront that the optic nerve is thickened and involved, then that is extraocular RB already and should be treated as extraocular more aggressively to prevent relapse. So that's what the protocol is saying, and we'll have the results hopefully in the next couple of years, and we'll know how that's changing things.
मैं एक कमेंट ऐड करना चाहूंगा कि एक तो मैं हाजिरी लगवा दूं कि मैं ऑनलाइन आपके साथ था, आई वाज मल्टीटास्किंग. दूसरे गुड टू सी हलीमा कि यू फर्स्ट हियर इन पाकिस्तान, क्योंकि शौकत खान में मैंने 11 साल काम किया है. एवरेज जो लाइफ थी पीडियाट्रिक ऑन्कोलॉजिस्ट की पाकिस्तान में वो 3 साल थी. वो
9.5 हो गई है सर. 9.5 years for me now.
तो आप तो इसका मतलब एमराइटस हो चुकी हैं. तो इट्स गुड कि वो उस दौरान में वो उसको इतना रोल देते थे शौकत खानम वाले, वो भाग जाता था. तो अब हमें खुशी हो रही है कि अब आप तैयार होगी पाकिस्तान के लिए. अच्छा, एक चीज मैं ऐड करना चाहूंगा कि हम ये ठीक है साइंटिफिक तो कर रहे हैं, लेकिन साइंस वुड नॉट वर्क unless we go into the public and we involve, we create the awareness. एक मैं आपको अफसोसनाक नुमा जो सुना दे. तो एक फैमिली थी जिसको मैं लुक आफ्टर कर रहा था, और उनके 3 बेटियां थी, जिनमें से 2 को रेटिनोब्लास्टोमा था जो हम ट्रीट कर रहे थे आपके साथ मिलके, और उसके दोनों पेरेंट्स रेटिनोब्लास्टोमा के लिए बायलैटरल इन्यूक्लेशन हुई थी, और उन्होंने आपस में शादी कर दी थी. और मुझे उनकी नानी का फोन आया बच्चों की, डॉक्टर साहब मुबारक होए, मुंडा हो गया एक साढ़े. एंड अनफॉर्चुनेटली दैट आल्सो हैड, दैट बॉय आल्सो हैड रेटिनोब्लास्टोमा. तो ये चीज जो मुंडे की तलाश में है, वो बेचारों ने देखे ना, एक मुसलसल वो कर दी। इसका हमें अवेयरनेस सोसाइटी में, इसके लिए हमें चाबी के निशान वालों को भी इन्वॉल्व करना पड़ेगा, सेक्रेटरी वालों को भी इन्वॉल्व करना, हर को इन्वॉल्व, चिल्ड्रन वाले तो जाहिर है हमारे साथ में। और ये जब तक हम ये नहीं करेंगे, ये बहुत बड़ा, ये आप जितना मर्जी आगे से हटाएं, पीछे से तूफान आता ही जाएगा। तो मेरी रिक्वेस्ट है, असद साहब बैठे हुए सर, एक कैंसर रजिस्ट्री की आपने भी बात की थी, अगर ये हम सारे इंटीग्रेट कर लें तो बजाय कि अलग अलग हम करते रहें, एक ऑलरेडी वो चल रही है। तो और आई कॉन्ग्रेचुलेट शबाना के, इन्होंने बहुत मेहनत की और एक प्लेटफॉर्म हमें दिया और हम मिलके काम करेंगे।
Okay. Thank you very much.
एक ही चीज ऐड करना चाहता हूँ। आपने बताया कि अर्ली डिटेक्शन, हम फोकस तो करते हैं टर्शरी केयर पर, एडवांस ट्रीटमेंट पर, नो डाउट अल्टीमेट तो वही है, लेकिन सबसे जो जरूरी चीज है ना, प्राइमरी आई केयर है। जब तक हम प्राइमरी आई केयर पर फोकस नहीं करेंगे, हमने रेडी हेल्थ वर्कर्स को ट्रेन किया पूरे पाकिस्तान में, मोर देन 1 मिलियन है इसको पाकिस्तान में, और उनको ट्रेन किया हमने, लेकिन जब तक हम प्राइमरी आई केयर पर फोकस नहीं करेंगे, कि वो बेसिक लेडी हेल्थ वर्कर्स हैं जो घरों घरों जाती हैं, और वो जाके, अब हमने उनके प्राइमरी आई केयर मॉड्यूल इनकॉर्पोरेट कर दी है प्राइमरी हेल्थ केयर के सिलेबस में, तो उसमें हमें फोकस करना पड़ेगा ताकि ये अर्ली डिटेक्शन वहाँ पर हो, क्योंकि वो जाकर बच्चों को देखती हैं कि और मैं ये को बताना पड़ेगा। तब तक हम प्राइमरी केयर यूनिट और रूल तब तक अगर नहीं करेंगे, फंगेटिंग माफिया, जहाँ जहाँ हम सब किसी करते हैं पॉलिसी मेकर्स को, तो हम प्राइमरी आई केयर पर फोकस करें, तो हमारा दैट इज द ओनली solution for early detection and early presentation to teaching hospitals.
That's a really good point. South America में उन्होंने स्टडी भी किया था, जो उनका इम्यूनाइजेशन प्रोग्राम है हाउस टू हाउस, विच इज सिमिलर टू पोलियो का है या जो हमारे लेडी हेल्थ वर्कर्स का था, एंड उससे स्टेज ऑफ प्रेजेंटेशन वेंट सिग्निफिकेंटली लोअर. So that is the level that we need to work at, is the lady health workers वाला या immunizers जो जाते हैं कि उनको train करें. The other thing that's worked in Africa is कि smartphones की apps हैं, Android के लिए भी हैं और दूसरे उसके लिए भी हैं, iPhones पे भी हैं. Cradle app है, I think शायद जिसका नाम है, which is जो तस्वीरों को assess करती है. तो तकरीबन पूरे पाकिस्तान के पास स्मार्टफोन तो पहुंचा वही है कि most people have it, a lot of people have it. खासतौर पे बच्चों की तस्वीरें लेते हैं. So if we can actually share that across even our families or groups or whatever, apps के links. So if all people with newborn kids download that app and start taking pictures, उसमें false positives बहुत आएंगे आपके पास, लेकिन ये है कि कोई बात नहीं, cataract pick हो जाएगा, right? You know, like anybody with an eye abnormality or a white reflex will get picked up when the parents, so you'll have more people coming in probably with false positives, but at least उसमें miss कम होंगे. So those apps are useful that have been used in Africa and are available at the app store. So that's something we can definitely share with families and try to promote ताकि उससे थोड़ा referral better हो जाए. Thank you.
Ladies and gentlemen, when discussing about retinoblastoma, we almost certainly do forget at times that there's an entire family that has been torpedoed with this diagnosis. And there's a very innocent child caught amidst all of this in these therapies, in surgery. And this has vast ranging social and psychological impacts. Let's hear it from Professor Nazir Shimran regarding the social and psychological impacts that retinoblastoma has on the community in general and on the child in particular. Dr. Nazir.
Thank you so much. First of all, it's wonderful to be here and interact with you. And thank you so much, Dr. Shabana, for inviting me to be part of this. जब भी हम बच्चों की फिजिकल हेल्थ की बात करते हैं किसी भी एस्पेक्ट से, इट्स वेरी वेरी इंपॉर्टेंट टू नो कि हर फिजिकल हेल्थ इश्यूज का जो है साइकोलॉजिकल और सोशल इम्पैक्ट भी होता है. And specifically when we are talking about diagnosis of any cancer, including retinoblastoma, it's a very traumatic experience, not only for the child, but for the whole family. और इसमें family, बच्चा, as well as the siblings, they all get affected by it, and every individual has different way of the effect or impact would vary from person to person, from child to child, based on so many factors. Unilateral है या bilateral है, then treatment options क्या है, financial aspects we all know कि that sort of is also plays a major role जब हम treatment की भी बात करते हैं कि what can be provided, whether it's cost effective और कितनी हमारी population afford कर सकती है. So all these things do have a toll on the whole sort of aspects जब हम, so it's very very important कि जब हम multidisciplinary team की बात करें, when we are looking after children's health and retinoblastoma care, the psychological and social aspect should also be covered. And in that, a holistic approach to the treatment is extremely important. Or as healthcare professionals, what is very important is that are we sort of able to counsel the family effectively? Breaking the bad news के जो basic principles जो HCP के होने चाहिए, they make a lot of difference on how the parents respond to it. इसी तरह से effective communication skills, listening skills, how the team can help families support or to express their emotions. So all these things are something जहाँ multidisciplinary team का बहुत important role आ जाता है कि how we can support the families and not only the child. As child and adolescent psychiatrist, मेरा major काम अगर मैं कहूँ तो वो parents के साथ होता है rather than the child. क्योंकि parents are the role model, they are the first teacher of a child. So doesn't matter आप किसी भी age के बच्चे को treat कर रहे हैं, it's important that if you help parents to look after themselves, if you listen to the parents' anxiety and fear, and there are a lot of research done कि parents में भी और बच्चों में भी anxiety, depression और post-traumatic stress disorder के symptoms जो हैं following these experiences, they do happen. But parents, if they are able to sort of express their emotions in a positive way, you can guide them how they can support their child emotional and physical well-being. इसी तरह से बच्चों के लिए play is the language of child. So carers can easily identify if the child is anxious, if the child is fearful by observing at the play of children. So play therapy का बहुत important role आ जाता है जब आप young बच्चों की बात कर रहे होते हैं, in order not only to engage them in the treatment process, but also how you can support their emotional well-being ताकि impact of the illness you can sort of look after their well-being in a holistic manner, not only looking at the physical aspect. So these were just some of the few thoughts that it's important कि multidisciplinary team में, especially cancer की diagnosis में, there is a very important role के psychological और social aspects healthcare के हम ना भूल जाएं, और उसमें whole family को support करना बहुत ज़्यादा ज़रूरी है in order to bring about improvement in the nation's health as well as the children well-being. So I'm happy to take any questions if there are. These were just few comments. Thank you so much. देखिए, generally child psychological services, if possible, should be involved from the beginning. Because that it's a process, it's not some magical solution which can happen. So how can you can help the parents support through the treatment process, and then you can prevent many things from happening if you intervene early rather than waiting कि किसी बच्चे में या family में कोई specific diagnosis होगी. At that stage, the child would get referral. At times, that's pretty late, and then treatment also takes much more time. Yes, at that time, at least healthcare professionals needs to be discussing about it कि जब news break की जा रही है, जब आप investigations offer कर रहे हैं, during that time जो parents की anxiety है, how they can be addressed by the treating team, that would be my sort of take on that. Okay. Thank you so much.
Thank you so much, Madam, for taking out your precious time. Now, moving on to our next presentations, I would like to invite Dr. Mehwish Faizan to please discuss systemic chemotherapy for retinoblastoma patients.
Bismillahirrahmanirrahim. I will be discussing with you the concept of systemic chemotherapy in retinoblastoma. So in the time allocated, I will give you a brief overview of the evolution of treatment, aims of treatment with systemic chemotherapy, some of the common chemotherapeutic agents being used, and a little bit about recent advances. As we all now know, retinoblastoma is the most common childhood intraocular malignancy, accounting for about 4% of all pediatric malignancies. And retinoblastoma, it's a chemosensitive tumor. And as we have already discussed, in advanced countries, the prognosis is even more than 99%. And that's only because they are diagnosed at a very early stage. And even the rate of globe salvage has markedly improved to more than 95% from less than 10% that was a decade back. And however, as we have seen the pictures too, in our country and in many of the other lower middle income and lower income countries, we do still see patients with advanced stage of the disease. And if I just talk of my own center at the children, we see on an average of about 20 to 30 retinoblastoma patients per year, apart from all the other malignancies that we see. So in retinoblastoma, the aim of treatment is to save the patient, to save the eye, and to preserve the visual function. And in cases of bilateral retinoblastomas, aim is to retain the vision and at least one eye. Mostly, or when required, we have to go for enucleation in the more advanced eye, followed by chemotherapy and focal therapies for the other eye. Now, if we talk of the evolution of treatment for retinoblastoma, initially the mainstay was enucleation and the radiotherapies. In 1950s, triethylene melamine was used, but it was abandoned because it was associated with severe side effects. And in 1970s, systemic chemotherapy was evolved, consisting of zinc cyclophosphamide for metastatic diseases. And it was in mid-1990s that chemotherapy became the mainstay of therapy for retinoblastoma. Carboplatin was found to be highly effective for intraocular retinoblastoma, and this was combined with aggressive focal therapies. Etoposide, topotecan melphalan, etoposide vincristine, they became widely used in the clinics. And from 2000, there is a trend from systemic chemotherapy to more local eye-directed therapy. So chemotherapy has a role in both intraocular and extraocular retinoblastomas. The chemotherapeutic agents, they can be given systemically, they can be given subconjunctivally or intraarterial or intravitreal. Intraarterial and intravitreal will be discussed in detail by my colleagues later on. So chemo can be given as a first-line treatment to reduce the tumor size for intraocular retinoblastoma. And when the tumor is shrunken in size, then it makes it more amenable to local treatment therapies. And the main effect of chemo reduction is after 2 cycles, as we have already discussed. And chemotherapy can also be given as an adjuvant therapy. That means it is given after enucleation to reduce the risk of metastasis. And the main aim of chemotherapy is to reduce the tumor size, to allow focal therapies to be more effective so as to control the residual disease and to eliminate the need of radiotherapies. As a general rule, usually 6 cycles of chemotherapies are given for intraocular, and about 9 to 12 cycles have been used for advanced stage diseases. Examination under anesthesia is done after every 2 cycles. The different chemotherapeutic agents that have been used include carboplatin, cisplatin, vincristine, etoposide, and then cyclophosphamide, topotecan, and doxorubicin. The most recommended protocol that's being used consists of vincristine, etoposide, and carboplatin, and it's given 6 cycles every 28 days when the CBC is normal, mean absolute neutrophil more than 1,000 and platelets more than 100,000, and child is hemodynamically stable. Even the UK guidelines for the management of children with intraocular retinoblastoma is using the JO chemotherapy, that is carboplatin, etoposide, and vincristine. And there have been studies which have compared the efficacy of 2 systemic chemotherapies that include the standard VC, that was Vinc, Etopo, and Carbo, along with cyclophosphamide. And they found that for the frontline therapy, cyclophosphamide didn't made much of a difference, or there was in the prognosis. So that's not routinely recommended. Our PSPO protocol, which Dr. Halima has discussed, is using these 3 drugs for the first-line treatment for intra and extraocular retinoblastoma. Now, in cases of second, if the child relapses or is resistant to chemotherapy and he needs chemotherapy, then there are options for second-line chemotherapy that include cyclophosphamide, vincristine, and doxorubicin. And then there is an increasing role of topotecan and vinc with doxo in metastatic, in relapse cases. And for stage 4 disease, which is extended into the brain or the CNS, usually intrathecal is used, and most of the patients who present to us with CNS disease, sometimes we have to palliate depending upon the extent of the. And in metastatic diseases, high dose chemotherapy and stem cell rescue is given. So whenever chemotherapy is given, when I compare it with other chemotherapies, it's not a very toxic chemotherapy. And with good supportive care, usually the side effects, they're manageable. And all the treatment can be given for the first line treatment on the outpatient basis. Usually the child should have a central line. We don't have the central line for all of our patients, so we use the peripheral line, but we have to be very careful while using the peripheral line. Antiemetics or anti-sickness medication are given as per the local protocol. And these children can get neutropenic, and you have to manage the febrile neutropenia, and all the residents should be well aware of recognizing and managing febrile neutropenia in these patients. Systemic chemotherapy is associated with side effects, and the common include bone marrow suppression, alopecia, ototoxicity, nephrotoxicity, and all of these needs to be monitored. AML is associated with high dose of etoposide, and with the radiotherapy, there is risk of local bone marrow hypoplasia and risk of secondary cancers. So when there is CNS is positive or CSF is positive, then intrathecal chemotherapy is used, and the conventional agents which have been used for intrathecal route include the methotrexate and cytarabine. The Joe protocol, it uses intrathecal cytarabine for CNS positive patients, and recently there have been trials on intrathecal or intraventricular topotecan. Now, despite improvement in the unilateral retinoblastoma, the treatment of metastatic or relapse disease is still, it's very difficult, and it's even more difficult in our part of the world. So there have been research going on to identify the deregulated pathways that can be targeted through novel treatment strategies. There have been research on the use of immunotherapy, especially GD2 gangliosides, and they're even effective in cases of pre-treated chemorefractory cases who have MYCN amplification. And then there is phase 1 trials being conducted on oncolytic adenovirus targeting the RB1 gene. And now there have been research going on non-invasive diagnosis of tumor dissemination, and it has been found that aggressive subtype 2 MYCN amplified tumor or ctDNA circulating tumor, DNA positive in liquid biopsy sample, they're more aggressive tumor, and they need to be treated with some different chemotherapies. So in short, I would like to say that retinoblastoma is a very curable cancer if diagnosed at a very early stage. It's one of the WHO GICC, that is Global Initiative of Childhood Cancer Targeted Tumor. They're chemosensitive tumor, and now there are more advanced options available for the treatment of these cancer. Preferred treatment will depend upon the disease characteristics, the histopathology, as Dr. Zunaira has very rightly mentioned, and the stage of the tumor. So identifying the high-risk features by the histopathological analysis is very important to make a plan of management for the patients. And patients with CNS metastasis, they have poor prognosis, even with the intensive chemotherapy. So to the residents, I would like to say that no matter whichever specialty you take or wherever you are placed, make it a habit to examine the child in detail, look for the red reflex, and do a detailed physical examination. Because if you just close your eye for a moment and imagine that how important is vision for us, then you will be able to recognize that how important it is to save the patient, to save the globe, and to save the vision. Thank you. If you have any questions, you're most welcome. Sure.
Oncologist asked for histopathology report before starting the treatment.
Yes.
But what I understand from your presentation that if we are suspecting retinoblastoma, we'll start with the chemotherapy before the histopathology report is there. Is it like this?
Basically, the treatment will depends upon the stage of the tumor.
B,
Like
C,
Dr.
D.
Khan clearly mentioned that obviously if it's like A, B, C, D, which stage it is. Obviously, if the first aim be to save the vision and to save the glow. Enucleation is recommended in cases in which you are not able to save the glow. Obviously, if you are able to save the glow, then that will be our first priority.
Mostly our patients clinically present when there is no vein, the eye is full of the tumor. So what would you suggest? We should do the enucleation first, or we should start the systemic chemotherapy first?
Even this set of patients fall into two categories, in which enucleation is possible and you do the enucleation and you stage and you give the chemotherapy. And in some of the patients, even enucleation is not possible. In that cases, you reduce the tumor first with chemotherapy, reevaluation is done after every 2 cycles, and then chemotherapy and
So I mean, you will start chemotherapy even if the histopathology report is not available.
Yes, and we work in liaison with our own ophthalmologists to decide whether chemo has to be given alone or chemo has to be given along with the other focal therapies. Thank you.
Thank you so much, Madam, for a very succinct bird's eye view of systemic chemotherapy. Now I invite on stage Dr. Lubna from Lahore General Hospital for overview of intra-arterial chemotherapy.
सर इसके बारे में
Assalamualaikum. I'd like to congratulate the Department of Ophthalmology, Mayo Hospital, on arranging such a wonderful symposium on retinoblastoma. And I'm really obliged to giving me the opportunity to talk on this prestigious forum. Chemotherapy has been the gold standard in treating retinoblastoma, and it has been a fate changer for these children having retinoblastoma, whether given intravenous or intra-arterial. As the intravenous is covered, well covered by Professor Mavish, I'm going to cover the intra-arterial chemotherapy for retinoblastoma, advantages and pitfalls. We are living in a country with a very high rate of retinoblastoma. A study quoted that 5 children per 1 lakh child develop retinoblastoma only in one city, and with proper retinoblastoma registry, this figure may even further rise. We are living in a country where enucleation is considered as a social taboo. A lot of families refuse treatment to avoid enucleation, and ultimately parents get to see their children dying disfigured of retinoblastoma because they refuse treatment. Here the need arises to decrease enucleation rates, save more eyes, and save more vision. Exploring the possibility of expanding intervention neuroradiology services to include the treatment for retinoblastoma was a good idea, and I'll be greatly thankful to Dr. Umair Rashid, who helped us in conducting this procedure. We started conducting intra-arterial chemotherapy in October 2017. It provided us targeted and direct delivery of chemotherapeutic agent into the ophthalmic artery, opportunity to use more potent drugs than those which are used in intravenous chemotherapy, better penetration of blood ocular barrier, higher drug concentration in vitreous and retina where it is exactly needed, and minimal systemic toxicity. We observed a real decrease in the rates of enucleation and a good tendency towards more eye salvage and vision preservation. All ICs are performed under general anesthesia with the patient heparinized. A microcatheter is used, and the drug is injected in a pulsatile fashion over 30 minutes, 1 ml per minute. These are the drug options which are available, and melphalan is the most used drug, and with the better studied safety profile. This is the age-safe dose, and the emphasis is there on this age-safe dose. It was described by Bobin et al. Way back in 2011. He described using
the dose from 3 mg for patients less than 1 year, 4 mg for patients 1 to 4 year, and 5 mg for patients 3 year and more. And we did a little modification in that, and this is actually what we practice in our hospital. This is the diagrammatic representation. Videos. यहाँ से भी मैं इधर से करता हूँ, presentation से करता हूँ, फिर से बात करता हूँ। Here the catheter is in the arch of aorta, and we are aiming to cannulate the common carotid artery next. And the catheter is advanced into the common carotid artery next. Here contrast was injected in the common carotid artery, and the branches of the middle cranial artery were highlighted. Here we identify the ophthalmic artery, which is arising at 90 degrees from the internal carotid artery. This is the ophthalmic artery, and this step is little time taking when we need to bend the catheter into a thin calibered artery, which is at 90 degrees. Next. Then the contrast flows into this artery. We never advance the cannula further in this artery, but the contrast is injected. Next. And in this video, we would say choroidal blush. These pictures demonstrate how it is going, and the last picture is showing a choroidal blush at the choroido-retinal complex. The videos are available separately if time allows. This is how a three-way cannula is used to inject the drug over 30 minutes. Next. So these are few examples of tumor regression. This was a 4-month-old child who presented with unilateral retinoblastoma as shown on the B scan. And tumor regression was observed after every session. This child did not require systemic chemotherapy, and she was spared of the side effects of systemic chemotherapy, and regression remained stable over 1 year after the last injection. This is another example. And this is a third example. The tumor is not involving the macula, it is superiorly adjacent to optic disc. So results are really promising with intraarterial chemotherapy. This is as tumor regression appears on B scan. The tumor was filling more than 50% of the eye globe, which made it classified to group E retinoblastoma. And the tumor regression was adequate after chemotherapy and in 2018. And now we are 5 years later having good follow-up, and the patient is surviving and doing well. But still, alongside these positive and promising results, we have pitfalls with intra-arterial chemotherapy. The first pitfall is the expense. So what makes ISC so expensive? This video was supposed to show you the disposables which are involved and which cost high and all are imported. Next, Ricardo. Other pitfalls include ocular side effects, the possibility of central retinal artery occlusion, chorioretinal toxicity, and orbital swelling. This is a further elaboration on the dose, the criteria described by Govind et al. In 2011, and the criteria which are used at our center. So we are following lesser dose to ensure lesser toxicity and lesser ocular side effects. Studies mention using melphalan up to 7.6 milligram in one session, and that of course gives better tumor regression. But using that did not led us to having orbital swelling that appeared third day post injection, and the child required transfusion of 1 pint of fresh frozen plasma. There was peripheral branch retinal artery occlusion, which was observed on EUA, but in spite of that, the child continued to have good vision. So we not recommend exceeding the dose beyond 5 milligram of melphalan. This is a child 5 days after IAC, 10 days after IAC, and he happily healed 15 days after IAC, and it was the only eye for that child. We need to carefully select the patient we are going to do IAC on. Unfortunately, we had this child who was 1 year and 3 months old, and she had a tumor which was pretty active as shown in the picture on the left side. It was highly vascular, but it was very peripheral inside in the extreme temporal periphery. And in this patient, unfortunately, we had central retinal artery occlusion leading to loss of vision. This another child also had central retinal artery occlusion, and maybe the common factor between these two children was the site of that tumor. So IAC is more suitable for tumors which are central, involving the macula, superior to optic disc, inferior to optic disc, and on the nasal side near to the central retinal artery. So this is also one limitation. Talking about the number of cases in which we have provided IAC, they came to be 29 cases. Of them, 19 were having only eyes and 20 were unilateral retinoblastoma cases with the other eye intact. And chorioretinal toxicity or central retinal artery occlusion was observed in 2 out of 29 patients. So saving 27 visions out of 29 eyes still looks promising. This is a comparison between eyes having group D retinoblastoma and eyes having group E retinoblastoma. Only 19 eyes are included in this comparison, 10 with group D and 9 with group E, and results are comparable. This is an example of a patient having group E retinoblastoma. We can see the exudative retinal detachment. It was the only eye of this patient. I counseled them that it is better to go for enucleation as the tumor is really advanced, but they did not want to lose the eye. And IAC was performed in 2019, and the child is still doing well, and he is having stable exudative retinal detachment, which did not improve, but still ambulatory vision is there. So intraarterial chemotherapy is promising, but it will never replace the intravenous chemotherapy, which is cheaper, available, and has no or less ocular side effects. These were 3 children who presented late with this horrible picture just because they refused enucleation at some another center before, and they did not want to lose an eye, and the 3 of them did not survive. So IAC helped us to improve options for the patients, to improve follow-up, improve compliance, and especially the patients who were having single eye and the enucleation of the second eye is more difficult decision, did benefit from IAC, and they are doing well. Thank you.
Thank you so much, Dr. Lubna. Now to expound on further adjuvant therapies for retinoblastoma, I invite on stage Dr. Usma Mushtaq from Children's Hospital. Bismillahirrahmanirrahim. I'll be talking about the adjuvant therapies we do in the retinoblastoma. Mainly talking about the adjuvant therapies, we have 2 basic things we do. This is the focal lasers and the cryotherapy. This is just an icebreaker because we are on this part of the team, or we are collaborating for this team to fight this cancer. Talking about the historical background, Legendick was a scientist who first used microwave applicator to treat a tumor of retinoblastoma in patients of a recurrent disease. And since then, other scientists also tried on this, and they developed modifications of these therapies. And nowadays, it's used as a primary sole treatment for group A retinoblastoma disease. After Legendick, Shields, in the literature, it's reported that Shields was a scientist who treated 188 tumors, and it found that it was successful. He was successful in 86% of the patients, although 27% patients had recurrence. After that, Abramson in 2004 reported that there was 92% patients showed regression with the focal lasers, and he published his studies. So there are two types of adjuvant therapies, basically transpupillary thermotherapy and cryotherapy. These are the main two types of therapies which are basically used in our part of the world or in our setup, which we have actually come across and which we are familiar with. And these are the ones which have been published in our PSPO guidelines and also in the national guidelines. So this is a mechanism of action. Actually, this is using heat energy to destroy the tumor cells. This heat energy, it is taken up by the tumor. It causes things. It causes actually the photocoagulation of the blood vessels, resulting in the decreased blood supply of the tumor, resulting in tumor death and necrosis. Or simply, the excessive heat, it causes the cell to undergo apoptosis very quickly and destroying the tumor cells directly. These are the basically two mechanisms of transpupillary thermotherapy. As two types of lasers that are being used. We usually use this green laser, 532 nanometers, but in addition to this, infrared 810 nanometers is also used. There's a slight difference in the mechanism of action of these two lasers, although both of them use photocoagulation, but the diode laser is actually thermotherapy. That is, it produces a temperature around 45 to 60 degrees Celsius and directly causes destruction of the tumor cells. And it's believed that the infrared does not cause the photocoagulation, it causes the destruction of the tumor cells directly, and it has a deeper penetration as compared to the green laser. So this is basically used for the small and posterior tumors, especially the group A tumors, which are less than 3 millimeters in diameter, and they are easily accessible by an indirect ophthalmoscope. Larger size tumors can be killed with or can be treated with the focal lasers once after chemo reduction. And moreover, it can be used to form a protective barrier around the peripheral retina prior to the cryotherapy or the plaque radiotherapy. And it can also use to ablate the ischemic retina to prevent the neovascularization and further retinal detachments. We can also use focal lasers for recurrent and the residual tumors after chemotherapy or chemo reduction. These are one of the few lesions which we see after regression caused by the local therapies. These two tumors, these were regressed, and I'm thankful to my friend Dr. Lubna, who's just presented for these images as she has RETCAM in Lahore General Hospital. The other thing, adjuvant therapy, is the cryotherapy. As you can see, this is how the cryotherapy is being done. We actually have a cryo probe, and we visualize the tumor with this indirect ophthalmoscope and this 20T lens, and then we apply the temperature to cause the freezing of the tumor. Cryo is actually a triple freeze thaw technique in which we use the low temperatures up to minus 90 degrees Celsius to freeze the tumor cells and actually cause it to rupture or burst. This causes the destruction of the endothelial cells of the blood vessels, leading to thrombosis and eventually causing the cutting of the blood supply, and eventually ischemic necrosis of the tumors takes place. A cryotherapy is usually done for the tumors which are anterior and they are small. One important use of cryotherapy is that it can be done before the chemotherapy, just 2 to 3 days, that is 24 hours before the chemotherapy, to increase the penetration of the drug to the vitreous seedings. And cryotherapy can also be done to the tumors which are not actually accessible by the focal lasers, by indirect ophthalmoscopy. Some of the tumors that are not actually posterior, they're somewhat anterior. So what we can do is we can incise the conjunctiva and actually apply the cryo probe to slightly posterior lesions as well. So this is basically the triple freeze thaw technique. We apply the probe directly to the tumor. First of all, an ice ball is formed. We wait till the ice ball is formed and the cryo probe gets detached, and then again the freezing takes place, and that is the point where we see actually visualize the whitening or graying of the tumor, and we say that this has been successful. Usually 2 to 3 cycles may be applied after 3 weeks or 1 month, depending upon how frequently we are examining the patient, but usually we examine the patients after 3 weeks or a month to see if we need to reapply the cryotherapy or the focal laser, as the case may be. Thank you so very much. Thank you, Dr. Asma, for a wonderful presentation. Now I invite Dr. Anjali for presenting intravitreal chemotherapy for retinoblastoma.
Assalamualaikum. Another modality is intravitreal chemotherapy for retinoblastoma cases. Indications. Persistent vitreous seeds after systemic intravenous chemotherapy, at least 4 cycles, and or after intra-arterial chemotherapy. Next indication is recurrent vitreous seeds after completion of treatment. And third is chemo-resistant new vitreous seeds. Few contraindications for these are high bolus retinal detachments, secondary glaucoma, vitreous hemorrhage that is obscuring the fundal view, and the diffuse vitreous seeding in all 4 quadrants. Drugs used are melphalan and topetocam. Melphalan dosage is 25 micrograms in 0.125 ml or 30 micrograms in 0.15 ml. Topetocam hydrochloride is 20 microgram in 0.1 ml with 0.9% normal line. It can be given every 2 to 4 weeks for 4 to 6 cycles. Techniques of our intravitreal chemotherapy. Modified injection technique can avoid the risk of extraocular tumor dissemination in tumor-filled eyes. Prior to injection, decide quadrant and site of injection according to the distribution of seeds. Avoid entry through tumor foci. Under aseptic measure, intravitreal injection is given through pars plana 3.5 millimeter away from the limbus. Following injection, triple freeze-thaw cryotherapy should be performed at the site of injection simultaneously on withdrawal of needle. Eyeball is gently giggled with some forceps for even distribution of drugs and reducing local toxicity. Then fundus is examined after injection to look for acute complications such as retinal detachment, vitreous hemorrhage, or retinal hemorrhage. Rinse the globe surface with balanced salt solution. Few complications are noted. These are vitreous hemorrhage, focal cataract, salt and pepper retinopathy, anterior segment toxicity in a form of iris atrophy after multiple injection of melphalan. Here we have a case of group E retinoblastoma. The parents refused for enucleation and the systemic chemotherapy was not working. In this case, we have given the intravitreal chemotherapy. You can see through at the distance of 3.5 millimeter from the limbus. We are injecting the injection melphalan. And at the injection site, we apply the cryotherapy immediately to avoid any dissemination of the tumorous cells. Thank you so much.
Last but not the least, it's always very important to ensure a good follow-up from all the patients. I invite Dr. Simreen to expound on further on that.
Thank you so much, Sidra. Assalamu alaikum. So the retinoblastoma follow-up guidelines. Overview, we are going to ensure that there is good follow-up by the multidisciplinary team, by both the teams, the oncology and the ophthalmology. Follow-up based on the stage and treatment modalities, and follow-up of the siblings and offsprings, and the financial issues. The crux of the follow-ups is, during the treatment, आपने जो follow-up करना है वो 4 weekly करना है. कोई भी आप laser लगा रहे हैं, क्रायो लगा रहे हैं, इंट्रा आर्टेरियल कर रहे हैं, इंट्राविट्रियल कर रहे हैं, ठीक है, तो उसमें आपने फॉलोअप हमेशा 4 वीकली रखना है. आपका ट्रीटमेंट हो गया खत्म, उसके बाद ड्यूरिंग फर्स्ट ईयर आफ्टर द ट्रीटमेंट 2 to 3 मंथली फॉलोअप्स करने हैं, और अंटिल द एज ऑफ 7 years 3 to 6 मंथली फॉलोअप पे आ जाना है. ठीक है, ये याद रखना है कि विद इन फर्स्ट 3 years रिकरेंस रेट काफी ज्यादा होता है. ठीक है, आपने ट्रीटमेंट कर भी दिया, मगर फर्स्ट 3 years आपने उसका ध्यान रखना है, उसको क्लोज फॉलोअप पे रखना है पेशेंट को. दूसरा ये है कि रिस्क पीरियड है फॉर एक्स्ट्रा ऑकुलर स्प्रेड का आफ्टर सक्सेसफुल ट्रीटमेंट, दैट इज 12 to 18 months. ये चीज भी जहन में रखनी है कि आपने एक दफा ट्रीट कर दिया है, आप सेटिस्फाइड हैं, आपने कोई रिलैप्स नहीं आ रहा, रिकरेंस नहीं आ रही, MRIs कराए सीक्वेंशियल वो ठीक आ रहे हैं, मगर 12 to 18 months आपने विजिलेंट रहना है. ठीक है, अगर इन्यूक्लेशन कर दी है एक चाइल्ड की, उसके बाद आपने फॉलोअप उसका किस तरह करना है, 6 weekly. ठीक, और हर दफा EUA करना है, और EUA के अंदर आपने उसका सॉकेट एग्जामिन करना है, जो कॉन्फॉर्मर है उसको देखना है, कोई डिस्चार्ज तो नहीं है, कोई एक्सपोजर तो नहीं है, प्रोस्थेटिक आए है उसको निकाल के पायोडीन से वॉश करना है, और पेपला स्पेशली हम पेपला मिस कर देते हैं, लिड को इवर्ट करना है और पेपला देखने हैं कि पेपला तो नहीं बन रहे. आपने सुपरफिशियल पैल्पेशन करनी है सॉकेट की, और डीप पैल्पेशन करनी है देखने के लिए कि कोई मैस तो नहीं फील हो रहा. उसके बाद अब फॉलोअप आ जाएगा कि ड्यूरिंग सिस्टेमिक कीमो रिडक्शन हो रही है, उसमें आपने क्या क्या पॉइंट्स देखने हैं फॉलोअप के लिए. लीकोपीनिया चेक करना है, ऑटोटॉक्सिसिटी, रीनल टॉक्सिसिटी. आपने आय के अलावा ये चीजें जहन में होनी चाहिए ताकि आप ऑन्कोलॉजिस्ट के पास उसी विजिट में उसको रेफर कर सकें. अब है कि फॉलोअप ड्यूरिंग कीमो रिडक्शन या एडजुवेंट थेरेपी हो रही है, उसमें 4 weekly फॉलोअप करना है to check the regression, vitreous seeds, any new tumors, and side effects and complications of the treatment you are doing. ये आपने सारी चीजें एक तो अल्ट्रासाउंड से भी चेक कर सकते हैं, और दूसरा EUA से तो आपने सारी चीजें एग्जामिन करनी है. अब हमने MRI ऑर्बिट और ब्रेन कब करवाना है फॉलोअप में. ठीक है, उसमें आपने एवरी 6 मंथली कराना है बायलैटरल RB के केसेस में टिल द एज ऑफ 5 years. अब ये एक चार्ट है जिसमें उन्होंने सिबलिंग्स का और ऑफस्प्रिंग्स का बताया हुआ है कि फॉलोअप्स किस तरह करने हैं हाई रिस्क और लो रिस्क के मुताबिक. ठीक है, अब फाइनेंशियल इश्यूज हमें मेयो में बहुत ज़्यादा फेस करने पड़ते हैं, क्योंकि कोई NGO नहीं है जो हमें सपोर्ट करती है. हमारे अपने डॉक्टर्स, पैरामेडिकल स्टाफ, सिस्टर्स, हम सारे खुद फंड्स जनरेट करते हैं, ऑफ्थमोलॉजी के भी डॉक्टर्स टीम्स और ऑन्कोलॉजी की भी, और उनकी बेसिस पे उनके सारे हम, जैसे इंजेक्शन बेलफलाना भी जिक्र हुआ है, टोपोटिकैन हुआ है, वो नहीं आता हमारे पास. ठीक है, हॉस्पिटल में नहीं आता, वो हम खुद परचेज करते हैं और पेशेंट को ऑप्शन देते हैं कि आप क्या चाहते हैं, कि अगर आपको ज़कात लगती है या सदके के पैसे हमारे पास होते हैं उनसे आप इलाज कराना चाहते हैं. अगर वो कहते हैं कि ठीक है हम कराना चाहते हैं क्योंकि हमें लगती है ज़कात, तो हम उनसे पैसे नहीं लेते. मगर जो अफोर्डिंग होते हैं और वो जो पे कर सकते हैं, तो उनको हम स्लिप दिखाते हैं कि ये परचेज किया है तो ये लगा है और आप इतनी पेमेंट फिर हमें दे दें. मगर वो बहुत ही कम होते हैं कि आप कह लें कि 10 में से कोई एक आधा, कभी वो भी नहीं होता, क्योंकि मेयो हॉस्पिटल में मेनली बहुत नॉन अफोर्डिंग पेशेंट्स आते हैं. तो दूसरा ये है कि हम ये इंश्योर करते हैं कि जब उसकी कीमो प्लान की गई है तो उसी वक्त हम EUA भी प्लान उसी टाइम में करें, उसके बार बार विजिट्स ना हो हॉस्पिटल के अंदर, ताकि एक ही उसके ट्रैवल एक्सपेंसेस बचें और पेशेंट कंप्लायंस भी इस तरह बेहतर होती है. थैंक यू सो मच.
This brings us to the end of our symposium for today. For closing remarks, I request Professor Mohammad Moin to take the stage.
Thank you very much for all the organizers and all the participants who've stayed with us. I think time चूंकि excitement के ऊपर थोड़ा ज़्यादा हो गया चूंकि everybody whenever they come to their talk they would like obviously to explain more and talk more. I think जो एक thing which we can conclude from this is what are the recommendations which you would like to do as a retinoblastoma group. अब मेरे ख्याल में इसका WhatsApp group बना ले and after that you can come up with the conclusions what you want. एक तो आप देख लें जिस तरह आपने कहा था रजिस्ट्री बनानी है तो उसका easier तरीका है फिलहाल easier है कि yearly अगर आपके पास total data है अपने patients का तो जितने hospital बड़े आपके साथ collaborate करते हैं उनसे क्या अलहदा unnamed group में आपको दे दें तो जोड़ के बना लेंगे तो immediately आपका पाकिस्तान में prevalence या मेरा मतलब जो उसकी रेट है या फ्रीक्वेंसी मेजर सेंटर्स में वो तो आप जनरेट कर सकते हैं इफ पीपल आर विलिंग अगर नहीं है तो सिर्फ एक प्रोविंस में कर लें उसके हिसाब से बट यू कैन वर्क ऑन दैट दूसरी आपकी गाइडलाइंस को आपने पब्लिश करनी है वो बना लें को बुक लिखनी है तो वो चीजें इसकी बेसिस पे आप सारा डाटा आपने एक बार सारों को रिवीजन दे दी है एवरीबडी नोज एवरीबडी सो इट्स अ नेटवर्किंग ग्रुप जो आए थे उनका एक ग्रुप बना लें एंड यू कैन मेक अ व्हाट्सएप ग्रुप एंड continues working on that. Baki, thank you very much, Asad Saab, for sitting here all the time. Sir, बैठे रहे. Khaja Saab, thank you very much for coming. Dr. Sumaira, especially for coming from Islamabad. Abid Saab from Children's Hospital. Asma चली गई है. बाकी Dr. Mahvish बैठी हैं. Dr. Halima बैठी हैं. Thank you very much, everybody. Dr. Lubna is here. Dr. Shabana ka probably. Thank you very much. She arranged everything, and I think she is in. उन्होंने मेहनत काफी ज्यादा की है तो probably I think we should have a big round of applause for her.